Hello, everyone. Welcome to today's briefing, and thank you for joining. I'm Jessica Bylander, a deputy editor and correspondent at Health Affairs. So we're delighted to have you joining us for today's briefing on the food, nutrition, and health issue. So the United States has for many decades been reevaluating its relationship with food through the lens of health. The nation is facing an epidemic of diet-related chronic diseases from cardiovascular conditions to diabetes and obesity. The health-related consequences of these diseases include reduced productivity, spiraling healthcare costs, and declining life expectancy. We are excited to host a virtual briefing focused on the concept of food as medicine, medically tailored meals, agricultural policies, the relationship between food security, income, and health, and much more. Today's discussion is based on insights from articles published in our April theme issue on food, nutrition, and health. We are grateful to the Kresge Foundation, the Kaiser Permanente Funds at East Bay Community Foundation, Episcopal Health Foundation, Blue Cross and Blue Shield of North Carolina Foundation, the Robert Wood Johnson Foundation, and the Rockefeller Foundation for their support of our work. During today's briefing, questions may be submitted through the Q&A tab that's at the bottom of your screen. Guests do not have to wait until the Q&A period to type in questions and should feel free to type them in the chat at any time during the sessions. Now it's my honor to introduce Sass Borodkin, the Executive Director at Resources for Organizing and Social Change. Today, they will present their poem, ETR.
When I was homeless and traveling by train, there was a lot of waiting around involved. One train schedule didn't match the next, so I'd pop a squat on mud-streaked linoleum, watching worker bees brushing by, a different pair of shoes on each. I began imagining whole lives in those shoes. Look at that Italian leather. It's a good steak tonight. A slab of medium rare ribeye with a side of dollar bills and a fancy lamp. Probably a promotion, too. Not like this other pair, though. Generic Nikes with a bit of back talk on the sole. Dinner probably looks like the late shift at Taco Bell, served up on a paper plate. Maybe a side of single dollar bill and a faint memory of that friend who couldn't afford rehab and became a faint memory in place of a sister friend. Much like my own pair. My own pair that talked back and served up oatmeal for dinner or nothing. Or nothing.
Thank you so much, Sass. Thanks for sharing your work with us and for being here today. Next, we will go ahead and move to our first panel of the day, which will be moderated by Hilary Seligman. Hilary Seligman is a professor at the University of California with appointments in the departments of medicine and of epidemiology and biostatistics. Thanks so much, Hilary.
Hello, everyone. Thank you so much, and thank you to Sass for that wonderful introduction. I'm excited to be facilitating our first panel today, which sets the stage for the rest of today's briefing by examining systems that sit at the intersection of food, nutrition, and health. The panel includes Dr. Seth Berkowitz, Associate Professor of Medicine, General Medicine, and Clinical Epidemiology at University of North Carolina at Chapel Hill, Dr. John Lumpkin, President of Blue Cross and Blue Shield of North Carolina Foundation, and Colin Schwartz, Senior Advocacy Advisor, Federal Healthcare by Food Advocacy at the American Heart Association. I will now turn it over to our first speaker, Dr. Seth Berkowitz, to start us off. Thank you, Seth.
Great, thanks so much, Hilary. So I wanted to just have a few remarks today about a paper that I worked on with Dr. Seligman as well as Dr. Mazafarian in this issue. So in this paper, we try to put together and also separate some interrelated constructs that are relevant for the topics in the theme issue overall. These include income, food and nutrition security, diet quality, and health. Next slide, please. So we essentially organize this with a conceptual model that starts off with income and recognizes that there are some impacts of income on physical and mental health that do not go through kind of food security, nutrition security, or diet quality, but some that do. And then there are these three constructs that we think are interrelated and correlated in some ways, but distinct in others. So food insecurity, as many people know, conceptually includes both the components of access to food quantity, but also the quality of the food. However, the measures that we commonly use for food insecurity really don't query questions of access to healthy food. And so there is some concern that food insecurity may, as measured by the common measures, may largely be reflecting sort of economic factors, but may not be capturing the full scope of ideas related to people's ability to access a healthy diet. This is kind of where the idea of nutrition security comes in. And so the validated nutrition security measures that now exist, there are two of them. And so these kind of more specifically query people's access to healthy foods. And finally, there's the idea of diet quality, the overall pattern and the healthfulness of the patterns of the foods that people are eating. And this is kind of maybe more proximally related to some of the health outcomes that we think about. It's important to note that, that separating these concepts is not just for academic reasons, but kind of has real impact on how you might try to intervene to improve people's health. Because health is a very multidimensional construct, different interventions may be better or worse suited to affect different aspects of health. And there's probably no one intervention that's going to affect all aspects of health. So for example, interventions that target income specifically, although they may make financial resources available to afford healthy food, may not overcome some other barriers to healthy eating that people may face, such as the availability of foods in their neighborhood, or issues of motivation, or the issues around marketing of hyperpalatable but nutritionally poor foods. Conversely, interventions like food as medicine interventions that really kind of specifically try to make healthy foods available to people, improving nutrition security and increase the diet quality that people are consuming, may impact different aspects of health, ones that are closely tied to diet, like chronic disease management indicators such as hemoglobin A1C and diabetes, or blood pressure for people with hypertension, and may do that in a way that's different than interventions that impact income alone might do. And next slide. The final point I want to make about the conceptual model is that we've presented it out in a single time period, which I think is important for understanding what the time ordering is and relevant for intervention planning. It's also important to recognize that there's a longitudinal component to this, and so the physical and mental health state that people experience at one time can feed back into the system and influence income, and then other factors like food insecurity, nutrition security, and diet quality at a later point in time. And so by intervening, you can interrupt some of these processes that would tend to worsen health over the long run as well. So there's a lot more in the paper. We try to, sort of both provide important definitions of these concepts, and we also review a lot of the existing evidence in light of this framework. And so we look at existing studies, how they fit into these different aspects of where interventions might be intervening, and how that might explain some of the results that various interventions achieve, i.e. interventions that focus, say, more on income, or more on food insecurity, or more on diet quality. And we think it provides a useful way to sort of unify what can otherwise be a complex and confusing field. We also note that there are still, plenty of further things to learn. So, particularly the interrelationship between food insecurity and nutrition security is an area that we're learning a lot more. As the concept was developing, some people thought, well, it'd be very difficult to be nutrition secure if you're food insecure, that nutrition security should be sort of nested within food insecurity in some ways. And yet when people actually go out and measure this, some people report nutrition security and food insecurity at the same time, which is just one example of something that might cause us to sort of rethink and tweak and reconceptualize some of these ideas, and also provide important places to study to get further clarity. So that's just one example that we talk about in the paper. I'm going to wrap up there because I know it's a packed group of speakers that we all want to hear from, and I'll turn it over to a friend and colleague, Dr. John Lumpkin at Blue Cross Blue Shield of North Carolina.
Thank you so much, Seth. And I'd like to start off talking about this topic and recognize the co-authors, Mary Davis and Valerie Stewart from the Blue Cross of North Carolina Foundation. And also to give my appreciation to Health Affairs for highlighting the importance of food in achieving health. And I especially find it rewarding to see the inclusion of community voices on the agenda and in this edition. And later today, you will hear from Sonya Jones from Hendersonville, North Carolina, as she shares her perspective on cultural and place-based wisdom and lifts up the unique value of community-based organizations and food as medicine. Through 25 years of working to improve food and health, working with local experts like Sonya, our foundation came to understand that healthy food is a part of a system of interdependent players who grow, distribute, and prepare food, all of them vital parts of their communities. 5 years ago, Blue Cross of North Carolina set out to not only prove the value of healthy food, but that there is a business case for including healthy food as part of a comprehensive approach of managing chronic illness to improve health outcomes and to make health insurance more affordable. Through piloting a food delivery health coaching program for members with type 2 diabetes, we're able to demonstrate better health outcomes and net reductions in medical expenses. These learnings were brought to scale through Feed Your Health program, one of the first in the nation to be offered to commercial customers as a no-cost benefit. The vendor that was selected for this program provides food services through for-profit channels, but also through a growing network of community-based nonprofits. Also in North Carolina, through the 1115 waiver, we see a pioneering of a screen and referral program and healthy opportunity pilots that includes fee-for-service payment to nonprofits for food insecurity interventions. Yet in our state, these examples are the exception rather than the rule. 2 years ago, I had the privilege to join our CEOs. We visited all 100 counties in North Carolina through the course of 18 months. There we met with leaders working together to improve the health of their communities. In Mitchell County, in the mountains of Appalachia, we visited a food hub called Tractor, which provided food as medicine through a clinical referral program, and at the same time, providing half of the income of over 70 local farmers. Another example, just a little bit further to the north, a food pantry called the Hunger and Health Coalition in Boone, North Carolina, provides medically tailored meals and food boxes while also supporting local farmers. And we saw many more examples of the engagement of the nonprofit community-based organizations in poor and underserved areas, improving access to healthy food while supporting their local economy. But it was during a visit to a community farm run by a small church in eastern North Carolina that the pieces came together about the impact of many current food as medicine models on organizations funded through charitable giving. This church-run community farm provides food boxes to local medical practice for their food as medicine programming, yet received no funds in return. And throughout the state, we saw the great advances as clinical pioneers were recognizing the value of food as medicine. But an unintended consequence was they were doing this through referrals to nonprofits set up to provide support for food insecure individuals. So with the best of intentions, healthcare was extracting resources from these organizations without identifying or mitigating the impact on them. Our paper presents an alternative approach, a generative approach, where healthcare meets the needs of their patients while supporting the nonprofit organizations that help their communities thrive. In this approach, community-based organizations are integrated as partners to healthcare providers, food as medicine vendors, and payers. And it's done via capacity building and infrastructure support. Simply put, paying for the service that helped them reduce the cost of care. In a generative approach, local food sourcing is prioritized, thus supporting smaller farmers and local economies. And philanthropic organizations have a role to play to help develop and support promising models that enhance the partnership between community-based organizations, health plans, health systems, and food as medicine vendors, all of which can result in better outcomes, but outcomes that are sustainable. To advance the development of a generative approach, further assessment needs to be made in establishing sustainable payment rates for services provided by community-based nonprofits. In short, a generative approach to food as medicine delivers more than healthy food, more than healthier patients. It delivers healthier nonprofits, a stronger local food system, and stronger and healthier communities. So thank you for listening, and now I'll pass it on to Colin from the Heart Association.
Great, thank you. Hi, everyone. I'm Colin Schwartz with the American Heart Association Healthcare by Food Initiative. I'm so pleased to present on our article, What is Food as Medicine Really? Policy Considerations on the Road to Healthcare Coverage with you all today. I'd like to thank my co-authors, Alexa Warman, Emily Holubowicz, Lisa Sanders, and Kevin Volpe. The purpose of this article is to describe that for healthcare coverage, particularly coverage for Medicaid and Medicare, it's important to have a very clear definition of food as medicine for a variety of reasons that I will briefly cover at this stage of the movement. I do want to note that stakeholders may define food as medicine differently for different purposes, which can all improve the food and nutrition environment, but this article is focused on why we need a core definition for purposes of healthcare coverage. I'll also note that to strengthen the evidence base around food as medicine, the American Heart Association and the Rockefeller Foundation, with support from other stakeholders and funders, launched the Healthcare by Food Initiative in 2022. We have since funded 25 research studies, the results of which we hope will ultimately inform coverage. And I'd be remiss if I didn't thank my fellow panelists today, Hillary and Seth, for being part of the initiative, and to John for his partnership. Next slide, please. So speaking of definitions, the American Heart Association defines food as medicine as the provision of healthy food, such as medically tailored meals, medically tailored groceries, and produce prescriptions to treat or manage specific clinical conditions in a way that is integrated with and paid for by the healthcare sector. We further define this in an appendix that's a supplemental material with the article that I encourage you to look at. Next slide. There are a number of policy considerations for FIM to be covered by Medicaid and Medicare. First, there are certain parameters for Medicaid and Medicare coverage. There are statutory and regulatory requirements that we mention in the article, and of course, a policy process that will require Congress passing legislation and the administration promulgating regulations. Second, a research base is needed to show clinical effectiveness and cost effectiveness. And related to cost effectiveness, I'll note that if and when Congress passes legislation related to food as medicine, Congress will rely on the Congressional Budget Office, or CBO, which will estimate, for instance, the increased cost of Medicare spending for FIM interventions and any decreased cost as a result of the coverage. So a standard specific definition of FIM is necessary in this context. An overly broad definition could include interventions that are too costly, for instance, or minimally effective. Third, we must ensure fidelity and quality in FIM interventions. Put in another way, essentially what's being called FIM is in fact FIM. This could take the form of a food company selling unhealthy meals that are high in fat or sodium and labeling them as medically tailored meals. So that's one example of FIM being FIM not being FIM. And then lastly, policymakers must know that FIM is distinct from, yet complementary to food and nutrition assistance programs and population-level healthy food policies and programs for two main reasons. One, in order to satisfy the policy considerations that I just mentioned for purposes of healthcare coverage. And two, because politically, classifying FIM as a food assistance program like SNAP, for instance, or a nutrition assistance program like school meals, or something like general nutrition education efforts, may inadvertently undermine policymaker support for any of these programs. For instance, if policymakers perceive SNAP to be FIM, questions may be raised about why healthcare should pay for FIM, or conversely, why SNAP funding should be independently maintained if healthcare would fund it. Duplication of services has been, is, and will continue to be a concern of policymakers. Accordingly, funding for Medicare and Medicaid FIM interventions should be understood as intended to supplement, not supplant or duplicate existing services. To show how FIM complements but is distinct to this food and nutrition ecosystem, we have a table in the article and a visual on the next slide. So next slide, please. I know this text may be hard for some to see, but on the left, you have food and nutrition assistance programs. For instance, SNAP, which is designed to improve access to food, and eligibility is based on income and is funded through the federal government. On the right, you have FIM, which is designed to improve an individual's health. It can also support improved nutrition security, but the main goal is to treat or manage specific clinical conditions. Eligibility is primarily based on health criteria rather than income, and FIM is paid for by the health sector, which could be private or public. In some cases, these are distinct populations with distinct needs. Many individuals with chronic conditions, for instance, are not eligible for food or nutrition assistance programs. Conversely, many folks eligible for food and nutrition assistance programs do not have a chronic condition. In the middle, however, for many people, there will be overlap of these programs. So for instance, someone may be low income and experiencing food insecurity and also have heart disease, in which case the person will both be eligible and benefit from SNAP in order to address their food insecurity and for FIM in order to address their clinical condition. And on the bottom and surrounding all of this, we have population level food policies that complement these programs to support a healthier population overall. Next slide, please. So that concludes my presentation. Thank you and look forward to your questions. And to find out more about our initiative and see all of our funded studies, you can go to our website at healthcarexfood, which is healthcarebyfood.org. And I'll turn it back to Hillary. Thanks.
Wonderful. Thank you to all of our panelists. We have a number of questions coming in through the Q&A. I'm going to start with throwing a foundational one out to Seth, which is, can you start us off by defining food insecurity and nutrition insecurity?
Sure, yeah. So I think of food insecurity as uncertainty around access to the food needed for an active, healthy life. And then nutrition security is an area where I think people are still converging on a definition, but one that the USDA has been using recently is they define nutrition security as when all Americans have consistent access to the safe, healthy, affordable foods essential to optimal health and well-being.
Great. Thanks so much. John, the next question is for you. How should the field think about or balance the desire to rapidly scale food as medicine with the potential benefits of a generative approach, which would require more upfront work?
Thank you for that question. I think that it has to go hand in hand. I don't think that we can delay the scaling of food as medicine. And what we found in our own experience working with Blue Cross is that much of our pilot work was done in a way that gave us a lot of lessons about what could work, how we make the business case. But when we began to move to scale, that's when we began to understand the importance of that generative approach. So as organizations are contemplating providing services, and this is really important for healthcare institutions that are looking at this, who are working in communities that are part of the communities, they should look for solutions within those same communities in ways that support nonprofits, enable them to grow, improving the conditions of the same people they're trying to treat.
And do you have ideas for how we might incentivize that work or push it forward?
Well, our real challenge is for us to, as a nation, to appreciate the fact that this is a real issue and to move from the current phase of trying to prove the economics of food as medicine to really beginning to move in that. One of the things our foundation is doing is we're in the process of developing a model. Part of the challenge of engaging with nonprofits for a health plan like Blue Cross is there are more than, there's hundreds of nonprofits in the food space in North Carolina. One single health plan can't negotiate with all of them. So our foundation is in the process of identifying a regional model that we'll use as a pilot to identify a coordinating center. And that coordinating center then would negotiate with all health payers and provide the flow of funds to the nonprofits as they move forward. So those are some of the things that we can begin to do to create the infrastructure to continue to engage nonprofits in a field where they have been taking the lead, providing food as medicine.
I love that. Thank you. Colin, I'm going to throw the next question to you because you laid out 3 essential elements to driving this work forward. And this audience question pushes us to weigh those. Despite the volume of evidence on the efficacy of food as medicine interventions, particularly interventions like medically tailored meals, and on the relationship between nutrition and health more broadly, these programs have yet to be embraced broadly by payers, at least by some payers. Which of these are really missing or needed to help move the needle on that front? Do we need more evaluation of individual programs, or should the field be more narrowly focused on the specific types of program designs or evaluations?
It's a great question. I would say for the purposes of healthcare coverage, we are building and expanding on an evidence base that specifically defines the FIM intervention, for which patient populations, for which clinical conditions, the duration, the dose, how is it implemented, what are also the wraparound services that go along with the intervention to show that it's clinically effective and cost effective. So there's been a lot of research done, but there needs to be more research related to that to convince payers and to convince policymakers to cover this, particularly for public health insurance. And in the article, we also lay out medical nutrition therapy as an example of how the evidence was built, the things that were put into place through the Institute of Medicine, or formerly now National Academy of Medicine report, what Congress did with that, what the administration did with that, just to show how much evidence you need and how specific the benefit needs to be in order to be defined, in order to be covered.
Thank you.
Can I jump in on that, Hillary?
Absolutely.
So what we found in our work at Blue Cross is that when you talk to actuaries, they're not looking for general programs. They're looking for the specific program that you're trying to convince them to cover. And so the kind of work that Colin is talking about creates, first of all, the evidence base. And then it leads up to the next one of saying, if we are doing this program, what is the return on investment that we can anticipate? And I think one of the critical things for researchers to understand, if it's cost neutral, it has a negative return on investment. Because what's not taken into account in most of the research is that for a health plan to implement it, they have to change some of the billing codes. They have to change so many other structures. And these costs have to be applied into the cost-benefit analysis that health plans do. So the research is absolutely incredible. It's very effective. It's very important. And then working with the health plans for them to go through their internal assessment processes.
Thank you, John. So I'll riff on that and send the next question over to Seth, which is another audience question. Why does the cost of care even matter? It doesn't matter in other medical interventions. Why does it matter here?
Yeah, I agree with that sentiment. I think there are a couple of reasons. One, I think the fundamental thing is that we really should try to avoid having a double standard for food as medicine interventions that we don't apply to other interventions. In the U.S. Healthcare sector, not only are most interventions not cost saving, but we actually don't even, routinely apply cost effectiveness criteria to making coverage decisions about interventions. And I think food as medicine interventions should be held to a similar standard. I think it's better to direct our resources towards cost-effective interventions, obviously. And I think, many food as medicine interventions may compete very favorably on those terms with already covered interventions. And so I think pushing our process towards that makes a lot of sense. I do think, though, in general, our goal with healthcare spending is not as a form of investment. It's a form of improving health. So in general, we don't necessarily cover drugs to to lower blood pressure or cancer treatments or any of the things we do in healthcare to spend less money per se. We do it to improve people's health. And I think holding food as medicine interventions to the same standard makes a lot of sense. To John's point earlier, I think as a pragmatic issue, particularly when many food as medicine programs are not being done as sort of core services, but through things like supplemental benefits and things like that. And this will depend a lot on the particularities of the insurance benefit that you're talking about, the product in the private market, or how it comes in as part of a Medicare Advantage plan or something like that. Then these actuarial considerations come in a little bit more strongly. But I do think that there is, in sort of a normative sense, no particular reason to focus in on costs only for food as medicine interventions and treat them differently than other healthcare interventions.
So, can I jump in on that one? Just because I wanted to, Seth and I have been working together for a while, and I think to just make it a little bit clearer, we have programs like Medicare and Medicaid, which are set, what's covered under those programs are mainly set by policy. Blue Cross has other customers. We have local businesses. We have national businesses that are self-insured. We don't determine what's in their package. We deliver to them basically a menu of potential benefits, and they purchase those benefits. So when it comes to the cost effectiveness, it's not convincing us on those programs. It's convincing, the bank. It's convincing other customers how important it is. And so what we were able to do with some of the work that we've done through some of our internal pilots is we were able to demonstrate that we could add this benefit at no cost. And I think that's part of what we need to learn in the food as medicine is where we can do it by policy, we should, and where we can, we have to make the business case.
So I'm going to throw the next question out to Colin, and it's related to this. One of the audience members asks about including disease prevention as part of food as medicine, or people at risk of chronic illness, not just those who are already diagnosed with or experiencing chronic illness. Clearly, this would have cost implications as well. Colin, can you start us off by helping us understand how we think about people at risk versus people already diagnosed?
I will go back to the research with this. We need to then see what studies show that's clinically and cost effective for different patient populations. So if you're at risk of heart disease or diabetes, but you don't have it, versus if you are living with heart disease or have diabetes and you have a FIM intervention, is that cost effective? Is that clinically effective? The research needs to show that in order for payers to cover it. Again, I'll just go back to the medical nutrition therapy as an example, that benefit is only for people living with diabetes or end-stage renal failure, kidney disease. And so there's a lot of advocacy that goes into expanding that for other patient populations. And then when beneficiaries get that benefit, it's very limited. So research needs to show the different patient populations, if it's at risk versus living with, what's that FIM intervention that actually is clinically and cost effective in order for a payer, especially for Medicaid and Medicare, to cover it.
Thank you, Colin. And I'm going to push the last question to you, Seth. Is food as medicine being considered only for low-income individuals? And if so, why are these individuals not being preferentially referred to SNAP, WIC, school meals, et cetera? How do we think about those systems next to each other?
Yeah, so I think that's a great question. I think food as medicine, I think very interestingly, has a history of coming out of both people who's are both sort of groups and sort of schools of thought that are primarily concerned about nutrition and that are primary, and then separately groups that are primarily concerned about the way that income and poverty affects health. And I think food as medicine has come together very nicely for that reason, but it does, I think, lead people to sometimes think that food as medicine may only be for people who, have lower income or are experiencing food insecurity as maybe an indicator of, economic issues and whatnot. I think Colin's graphic from his article made clear that there are certainly plenty of people whose need for food as medicine is rooted in issues of low income, is rooted in issues of food insecurity. But there are other people who may need food as medicine interventions for reasons that don't have anything to do with income and those kind of things. And in general, most food as medicine interventions are not means tested in a way that SNAP or WIC might be. I'll also say there is I think there's some debate in the field. I personally consider WIC a food as medicine intervention and sort of a prototypical one, whereas I think of SNAP as being a separate intervention. And in terms of, sort of pushing people to one or the other, I think the most important thing is to think about what are all the types of support that people might get. To use sort of a classic healthcare example, if we're managing someone with diabetes, I wouldn't be choosing between lifestyle intervention and medications. I would use both to try to improve people's health as best as possible. And, particularly in the food and nutrition space, if someone is eligible for SNAP and not currently receiving those benefits, then helping people enroll in SNAP can be a great strategy. But if they also might be eligible for a food as medicine program, say they have diabetes and food insecurity, and it's been demonstrated that a particular food as medicine program would improve health in that case, then I would, encourage people folks to try to set up systems that get folks enrolled in those programs as well. So I don't think it's an either or question. I think it's sort of bringing the resources to bear to sort of improve people's ability to take care of their health as best as possible.
Wonderful. We are unfortunately at the end of our Q&A period. I want to thank our panelists for a really rich discussion. Thank you all for setting us up on the right foot. At this time, I would like to pass things off to Dr. Darius Mozaffarian, who will facilitate the next panel on food as medicine. Dr. Mozaffarian is a cardiologist, public health scientist, and director of the Food as Medicine Institute at the Friedman School of Nutrition Science and Policy at Tufts University. Dari, over to you.
Thank you so much. Really wonderful to be here as part of this great event. A big thank you to Health Affairs for having the vision to have this issue on food and nutrition and health, which I think is a really terrific issue. I'm going to introduce the three speakers in our session, and each of them will present, and then we'll have a Q&A. So in the audience, please put in your questions. So we're going to hear from three great researchers about their new papers in this issue. The first is Kaitlyn Fruin. She's a fellow physician in the Department of Medicine at the University of California, Los Angeles. Second, we're going to hear from Amy Deng. She's a PhD student in the Food and Nutrition Policy programs at the Friedman School of Nutrition Science and Policy at Tufts University. And then we're going to hear from Ronit Ridberg, who's a research assistant professor at the Food as Medicine Institute at Tufts University. So Kaitlyn, turning it over to you.
Thanks so much, Dr. Mozaffarian. Hi, everyone. My name is Katie Fruin, and I'm thrilled to present on behalf of my co-authors our study in urban farm-anchored produce prescription programs' impacts on weight reduction. Next slide, please. I want to take a moment to provide context for the setting of our study, the West Side of Chicago. I grew up on the West Side, and it's an amazing part of the city that has a rich history of community-based food as medicine solutions. On the slide, you'll see a photo of Chairman Fred Hampton at the Black Panther Party's free breakfast program. And on the far right, you'll see an image from Dr. Martin Luther King Jr.'s Chicago Freedom Movement, which included Operation Breadbasket, an initiative focused on promoting Black-owned food products and for hiring Black workers across the food system, which resulted in 4,500 new jobs and more than $57 million in income for the Black community. I love their catchphrase, which encouraged their community members to keep a slice of bread in their communities, which highlights that while today we're talking about food as medicine, on the West Side for generations, food has been a form of economic power. So despite the West Side's rich legacy of advocacy and organizing, the cumulative impacts of systemic racism, deindustrialization, and mass incarceration on the area have been profound. In the North Lawndale community, where our intervention is based, today more than 1/3 of residents live below the federal poverty level. There is no supermarket or commercial pharmacy in the neighborhood. Only 38% of residents report easy access to fruits and vegetables, And the community suffers from a high burden of preventable diet-related conditions, including a 42% rate of obesity and an 18% rate of diabetes among adults. Next slide, please. So seeing the need for fresh produce to treat food insecurity and prevent and manage disease, and the need for meaningful employment, especially for youth and formerly incarcerated individuals, two long-standing anchor institutions, the Chicago Botanic Garden and the Lawndale Christian Health Center, a federally qualified health center, came together to transform a vacant lot in the heart of the North Lawndale community into the farm on Ogden, an urban farm with a 7,300 square foot indoor greenhouse, a 50,000-gallon aquaponics system, a year-round indoor farmers market, commercial and teaching kitchens, a summer job training program for local high school students, and a job training program for formerly incarcerated residents. My co-author, Katara, grew up in North Lawndale and actually first started working at the youth farm as a teenager, and now she is a manager of the farm's VeggieRx produce prescription program. Katara is traveling today, but she wanted me to share this reflection with you from when the farm first opened. She said, living in North Lawndale, it's a food desert. So when the farm on Ogden first popped up, nobody really knew you could go inside of it. If you looked at it, it was intimidating because of how fancy it looks. In North Lawndale, the city doesn't invest as much. So sometimes when buildings pop up, people think it's not for me. We had to think of a lot of creative ways for people to use the farm and to show that this is a space for the community and that we too can have nice things and beautiful buildings, just like other communities in Chicago have. Next slide, please. Thank you so much. So to build a local food as medicine ecosystem, first, the system is powered by more than 100 trainees each year who are employed to learn about urban agriculture and to grow and harvest produce. This produce is then packaged by a local distributor. Clinicians can prescribe VeggieRx prescriptions, which are a box of fresh fruits and vegetables that patients can fulfill with a dietitian weekly at the farm on Ogden, which is just down the street from the health center's main campus and located next to a bus and train stop. Patients can also receive nutrition and cooking programming at the farm, and then the year-round indoor farmers market is open to the community and sells subsidized produce Tuesday through Saturday. Next slide, please. In this study, we evaluated whether the VeggieRx produce prescription program administered by clinicians at the health center and fulfilled by patients at the farm on Ogden was associated with weight reduction. Next slide, please. We employed a retrospective propensity-weighted design with a non-random sample of 680 VeggieRx recipients that we used propensity-scored weight to match with a synthetic control group of 981 weighted controls. All participants were active patients at Lawndale Christian, and the primary outcome we evaluated was change in weight, and secondary outcomes were change in percentage body weight and glycated hemoglobin. Next slide, please. We found that at 18 months, the VeggieRx group experienced a statistically significant mean weight difference of negative 6.71 pounds and a negative 4.7% body weight reduction relative to controls. You can see this illustrated in Exhibit 3 on the right, where you can see the intervention group in orange, the control group in blue, and over time we see a reduction in the VeggieRx group and an increase in weight in the control group. Our study is among the first to document sustained weight loss over an 18-month time period on recipients of produce prescriptions. And then reductions in hemoglobin A1C were not significant at any time point. Next slide, please. So I'll just close with a closing thought from Katara on the importance of anchoring the VeggieRx program to the community through the farm on Ogden. Katara said, "It's important for us to see where our food comes from. I know for myself when I was young, I didn't know food could be grown in the neighborhood. I thought food had to come from a big farm. When I started growing produce at the North Lawndale Youth Farm, it blew my mind that you can grow produce in your backyard or on your porch. Growing produce can be a tangible part of your life. I think green spaces are really important because they reduce stress and they give us new hobbies. A lot of our kids don't know about farming because they aren't exposed to it. So exposing people to green spaces is important not just for adults, but for our children. We need to be the next generation of farmers. We need to eat hyper-local produce because it has denser nutrients. We need to invest in smaller farms. There are a lot of farms in Illinois. There's no reason we need to import the majority of our produce from somewhere else. Let's grow right here together. So thanks very much for letting me share. I look forward to your questions. And please, when you have a chance, make a trip over to the west side of Chicago and come grow with us at the farm on Ogden. Thank you very much.
Hi, thank you. Is this? Yeah. I'm Amy Shuyue Deng. I'm a PhD candidate at Tufts University, Freeman School of Nutrition Science and Policy. I'm pleased to share my study estimated impact of medically tailored meals on healthcare use and expenditures in 50 US states. And first, I want to thank for all co-authors' inputs. Next slide. So first, let's talk about what are medically tailored meals and why do they matter? Medically tailored meals are specially prepared meals designed by registered dietitians to address suboptimal diet as food is medicine for people with diet-related disease like diabetes and heart disease. Previous studies have shown medically tailored meals can improve health outcomes and reduce hospital visits. However, their effect at state level was unclear. Next slide, please. For our method, we use data from two main sources. First, medical expenditure panel survey. We have requested restricted data for 29 most populous states. And in order to estimate the eligible population, we also use behavior risk factor surveillance system data. And our eligible population is set for adults with Medicare, Medicaid, or private insurance with diet-sensitive condition and limitation in daily activities. Next slide, please. For the effect size estimation and simulation model, we conduct meta-analysis of study published from 2013 to 2023, examining medically tailored meals effects on hospitalization and costs. Most of the study we include found reduced utilization and costs, and our estimates represent a pooled effect across all states. We then use those estimates of effect size and state-level baseline hospitalization and healthcare spending to estimate state-level averted hospitalization and cost saving. To account for uncertainty, we ran 1,000 Monte Carlo simulation using 3% annual discounted rate. Next slide, please. First, let's talk about the result of hospitalization prevented per person. The number of medically tailored meal treated person that would prevent one hospitalization per year ranged from 2.3 in Maryland to 6.9 in Colorado. And nationally, we find medically tailored meals would prevent more than 3.5 million hospitalization in the first year. Next slide, please. And for healthcare saving per person, we find medically tailored meals could reduce healthcare costs in 49 states, with saving ranging from $700 to $6,000 per person. And medically tailored meal was cost neutral in Alabama. Nationally, we find medically tailored meals could save $33.1 billion in the first year. And this result is estimated based on the eligible population estimated from the BRFFS dataset. Next slide, please. For the state level variation in cost and impact, the cost saving and averted hospitalization per person was modestly correlated, but with notable exceptions. For example, Maryland have only around 3,000 saved per medically tailored meal treated person, but high efficiency, around 0.45 averted hospitalization per person. And for Connecticut, around $6,000 saved per patient, but lower efficiency around 0.25 averted hospitalization per person. In addition, we find regionally, South and Midwest have shown stronger correlation, and Northeast and West are less correlated. Next slide, please. In conclusion, nationally, we find medically tailored meals could save around $32 billion and prevent more than 3.5 million hospitalizations in the first year. And medically tailored meals can benefit state healthcare programs by lowering healthcare use and costs for adults with diet-sensitive condition and activity limitations. Our findings support state-level scaling and implementation of medically tailored meals. In addition, our study also informed the design of future interventions and research to enhance medically tailored meal effectiveness and reach. Next slide, please. In one sentence conclusion, medically tailored meals may reduce hospitalization, lower costs, and support health. And next slide, please. Thank you, that's all. And I'm happy to hand it to Dr. Ronit Ridberg.
Great, thank you so much. It's a pleasure to be here. I want to acknowledge first my co-authors, Julia Sharab, Kathryn Garfield, Erica Hansen, and Dari Mozafarian, and really pleased to share our research, Food as Medicine in the US, a national survey of public perceptions of care, practices, and policies. Next slide, please. So we conducted the first national survey to understand what people thought about food as medicine, what people thought about food, nutrition, and health in the intersections. We conducted this between February and April 2023, and we had 3,009 respondents across the United States. We targeted our demographic sampling to reflect the 2020 US Census on age, gender, geographic location, race, ethnicity, and income. So we did oversample in the two lowest income categories for household income. We had four major focus areas. First, we wanted to understand individuals' knowledge of diet-related medical conditions and the relationship between nutrition and health. In addition, we were curious about perceptions of healthcare providers' role in the prevention and treatment of these conditions. We were curious about direct knowledge of or experience with food as medicine programs and policies, as well as direct household experience with food and nutrition insecurity. Next slide, please. So in addition to the demographics, which, as I mentioned, targeted the 2020 census, we found that 42% of our respondents experienced food insecurity, 44% reported nutrition insecurity, and about a third reported both food and nutrition insecurity in the prior year. About half of respondents reported at least one diet-related health condition that was diagnosed by a physician. A third had Medicaid for insurance, 31% private insurance, and 22% Medicare. And 42%, as I mentioned on the previous slide, had household income annually under $50,000. Next slide, please. So one of the first key findings that I'll share with you is that overall comprehension and understanding of the link between nutrition and health among respondents was very high. 90% agreed that eating more healthy foods is important to prevent the onset of many health conditions, while almost that many agreed that eating healthy foods should also be a priority in treating major health conditions. 81% in addition agreed that their health depends on what they eat on a regular basis. Next slide, please. On the other hand, when we asked individuals to talk about their experience or to respond to questions about their experience with healthcare providers making the link in clinical encounters between nutrition and health, that level of experience was low. So less than half of respondents, 48%, said that their primary care providers in the last year had given them dietary advice. 41% said that they had been asked questions by their providers about their dietary habits. Even fewer, under a quarter, responded that they had been asked by their primary care providers if they had enough food to eat. And even though we reported that more than 50% had at least one diet-related or diet-sensitive condition, only 17% had seen a registered dietitian nutritionist in the last year. When we looked at some of these questions within subgroups, we saw some gaps existing. So for example, for those who were in the lowest income bracket, under $25,000 a year, only 34% were asked about their diet compared to 41% overall. And for those who had Medicare as their insurance, only 16% were asked if they had enough food to eat compared to our overall sample of 24%. Next slide, please. We asked some questions about what would inspire people to change what they ate, to change their behavior around diet and nutrition. And individuals said that they would be more likely to change what they ate if, for example, they knew that they would reduce the risk of future health conditions by doing so. 87% responded that way, with another 84% saying they would change what they ate if they knew it would help treat an existing health condition. In addition, more than half said if they had more money to spend on healthy food, or specifically if healthcare provided for or reimbursed for healthy food, that they would change what they ate. So 52% and 58% if they had more money. Next slide, please. In addition, respondents really wanted to talk about food and nutrition and diet with their healthcare providers, and they believed more training was necessary. So about 8 in 10 respondents agreed that more nutrition training should be provided in medical education, and more than half felt that their care team or that the healthcare system should try to help people eat better, that in fact it was not just a personal issue, but it was in the purview of the healthcare system or their healthcare team. Next slide, please. Overwhelmingly, we saw interest in participating in food as medicine services or programs, even though when we first asked respondents if they had heard about food as medicine programs like medically tailored meals or groceries or produce prescriptions, about 30% had previously heard of them. But when we described those programs, defined them, and then asked if they would be interested in participating if it was offered to them in their healthcare system or from their provider, more than half agreed they would be interested. And when we looked at those who were experiencing or had experienced food and nutrition insecurity, that proportion increased between 64% who are interested in medically tailored meals and 70% who are interested in receiving nutrition counseling. 2/3 of respondents agreed that Medicare and Medicaid should help pay for food as medicine, and 54% agreed that private health insurance should pay for food as medicine. Next slide, please. So to summarize, we saw that the comprehension of the link between nutrition and health was very high, but the experience with healthcare providers making that link in clinical encounters was very low. We also found broad public support, and we believe this signals opportunities for expanded coverage by Medicare, Medicaid, and private health insurance in food as medicine. We saw strong interest in engaging with care providers around diet and support for increased nutrition training for healthcare professionals. Finally, we see potential demand for increased efforts by grocery stores, pharmacies, farmers markets, and food delivery programs to partner with health systems, insurance providers, and technology vendors to incorporate food as medicine approaches in retail offerings. Next slide, please. And I'll close by saying I've shared just a small portion of what we found in this survey. We have complete survey results available in our appendix online at Health Affairs, and I thank you so much for your interest. And I'll turn it back to Dari now to facilitate our Q&A.
Thank you to everyone for your great presentations and especially for the great research. So I encourage everyone online to read the papers. The papers obviously have a lot more excellent detail. So we have several questions that have come into the Q&A, and if you're in the audience and you want to add, please do so. Ask first a question for Dr. Fruin. For your program, your Veggie RX program, who chose the content of the boxes, and how was that? How are the contents of the boxes formulated?
Yeah, so the content of the boxes is seasonal based off what we're growing at that time. And then our dietitians worked with community members to come up with recipes to put in the boxes, and with our nutrition partners to have our culinary classes feature the different produce that's in the boxes for the week and the season.
Great, thank you. That's very helpful. And then there's a question for Amy. Amy, in the studies that looked at sort of the intervention effects and the reduced hospitalizations, what was the duration of the studies, and how fast do you see the reduction in hospitalizations? Is it within the first year? Does it take longer?
Yeah, I read to the literature review. I find usually the duration range from around 6 months to around a year, and the effect also vary depending on the on the eligible population, the intervention targeting tool, and the duration. And I remember in general, the longer the duration, the better the effect.
But the reduced utilization was seen while they were on treatment. While they were receiving treatment was when they saw the reduced hospitalizations and utilization, right?
Yes, yes, yes.
Yeah, so it's a fairly quick effect. Yeah. There's a question for Ronit as well. How did you mentioned that folks were defined as food insecure or nutrition insecure? How did they identify as that? What was used to identify them?
Yeah, absolutely. So in our survey, we used the 2-item hunger vital sign to identify risk of food insecurity or experience with food insecurity. And we used the 2-item nutrition security screener that was developed by Tufts University and Kaiser Permanente and the LA County Department of Public Health.
And maybe can you expand a little bit on that latter? Someone also asked related to this, what were some of the barriers to healthy eating that you identified? If people said they felt insecure, why did they feel
what did that mean?
Yeah,
absolutely. So the NSS, the nutrition security screener, asks how hard it is to access healthy food, and then presents 13 different barriers to healthy eating. We all know there are challenges to eating healthy food. Overwhelmingly, the top barrier was cost. So 83% of respondents said that healthy foods were too expensive. Almost as many, 79%, said that their traditional foods in their family were maybe not so healthy. Somewhere between 52 and 57% also said that, there was lack of healthy food in their stores, or that the stores that had healthy food were too far away, or they didn't like the taste. And I will share one last barrier that might be surprising given some of the earlier conversations we were having in the first roundtable, that nearly half of the respondents in our survey, so about 1,500 people, said they were not sure if they qualified for food assistance programs, and that was a huge barrier to healthy eating.
Thank you. Another question for Dr. Fruin. Your Veggie RX program was connected to an urban farm as opposed to another location. How does that, do you think, makes that program unique, or gives you particular insights?
Yeah, well, I think something that's important on the west and south side of Chicago is, like many places across the country, there is a lot of turnover in grocery stores. So the city of Chicago will give taxpayer incentives for grocery stores to come to a community. As soon as those tax credits run out, the grocery store leaves. And so having an urban farm anchored in the community is important, because it not only provides produce access for patients at the health center, but it provides consistent access to produce for all of the residents in the community. And it really kind of changes the way, too, at the health center, providers are having conversations with patients around food. Definitely as a medical student, when I rotated at Lawndale Christian, they're talking about food as medicine in almost every visit. Whereas at my medical school and our clinics in the hospital, we're just not having those conversations as much. And I think it's in part because our providers honestly don't know where they can send our patients to get subsidized fresh fruits and vegetables.
Great, thank you. A question for Amy. One person asked particularly about Maryland's results, but I think more broadly, why were there some differences between the states? Why did some states have higher savings or lower savings, or higher hospitalization reductions or lower reductions?
Yeah, thank you for the question. So there are a few main drivers for the state's variation. The first few are the eligible population size are different states to states, and also the baseline healthcare costs and hospitalization are also different by states. In addition to that, the state-specific healthcare management strategy are also one of the main reasons. For example, Maryland has a global budget program and set fixed annual hospital budgets. And this can impact cost saving and hospitalization differently comparing to other states.
Thank you. And related to that, the paper was published a few years ago suggesting that if medically tailored meals were provided to everyone eligible, it would save about $14 billion. And now this new analysis, a little more than double, 32 billion. Why has it gone from a 14 billion estimated savings a few years ago to 32 billion today?
Yeah, thank you for this question. So for this analysis, because we request the state level restricted identifier from the MAPS dataset, and they only provide us for the 29 most populous states. So we need to use another dataset, which is BRFSS, to estimate the eligible population for all states. And the BRFSS have a higher proportion of people with disability. So that's why our eligible population size are larger, and coincidentally, the total national result will be larger than the previous study, but this will not affect the state level average for our per person result.
Right. And so I think BRFSS asks people if they have limitations of daily living. The original MEPS data set was using healthcare records. And so healthcare records may miss people who feel like they have activity. So I think before it was about 7 million eligible, and now it's estimated about 14 million people are eligible. So still a small number, but roughly double maybe are eligible than was previously estimated. Thank you. That's helpful. So a question for you, Dr. Ridberg. Were you surprised, and was there any hints from some of the qualitative or open text answers? Why were maybe not more numbers of people interested in participating in food as medicine? I think it was roughly 51 to 59% overall, and maybe 60 to 70% among people who are experiencing food and nutrition insecurity. Why? Do you have any insights of why that's not higher?
I mean, I think, this field is moving so quickly, right? So we conducted this survey 2 years ago almost, and I think that there's been an upswell in programs that are underway, in policies that have changed, in states supporting food as medicine, certainly in our advocacy efforts overall in the field, that I think that might be one reason why we saw, I mentioned 30% of respondents had heard of these programs. But I think that the findings show that people are really interested in talking about nutrition and health, in connecting with their providers on these topics, and in actually receiving and consuming food provided by healthcare.
Yeah, thank you. And then a related question you could address is 82% of people said they would change their eating habits to treat an existing condition. That's pretty high. So were you surprised by how high that was? And is there a disconnect maybe between how many people would be willing to consider food as medicine versus the doctor's, guidance and care they're actually getting around nutrition?
Yeah, I think I'm not surprised that people would want to do that if they knew that it would. I think there's a gap there in an educational need. So we also need to be sort of broadly trained and understanding that food actually can help treat and prevent medical conditions. And I think that there's this other element of other behavior change that's required. So it's not just about eating that food. So if someone says, yes, I would be happy to eat healthy food if it could, prevent this condition, but we need to increase our cooking knowledge and our, access to the healthy foods that are in the stores close to us, and cooking skills and time to cook. I mean, there are so many, as we saw in our barriers question, so many other barriers that need to be addressed at the same time, so that an individual who has that desire can actually make it into a reality.
Yeah, I think that was particularly interesting that we think of cost, and that many interventions to address food insecurity try to address maybe cost or resources, but there's so many barriers beyond cost. Many reported by more than 50% of Americans around knowledge. And it's not just even access, physical access. We also tend to think about food deserts. But beyond that, there was family and cultural preferences, cooking skills, cooking equipment, physical disabilities, just even knowledge about what's healthy. So it's remarkable how many different barriers there are that have to sort of be thought about. Dr. Fruin, there's a question about if someone was at a health center wanting to start up a program like this, where could they seek funding? How did you fund this program? Do you have any suggestions for funding?
Yeah, so an important catalyst and of funding for the Farm on Ogden was the U.S. Department of Agriculture's GusNIP program, which provides funds to patients taking care of Medicaid patients to connect them with produce prescriptions. And I'm hoping, as the government is reviewing grants, that the DustNet program gets funded several magnitudes more. I've seen across the country so many great produce prescription programs that have been funded. And then we're also fortunate to have private philanthropy that is supported. I would also encourage health centers to reach out to their local health systems. You know, all health systems have community benefit requirements. And I think partnering with our large anchor institutions, our large multi-billion-dollar nonprofit health systems to get them invested in food as medicine could really be another important catalyst to spreading these types of local food as medicine interventions across the country.
Great. And we just have a couple minutes left, so there's a couple of questions that maybe I'll just touch on quickly. So, you know, one question asked about what about multivitamin supplements, and there's pretty overwhelming evidence from randomized controlled trials that multivitamin supplements don't really do very much in the United States. And so I don't think that really replaces food as medicine. Of course, if someone has some specific deficiency and needs treatment, but just taking a general multivitamin is probably more just wasting money that could be spent on food, I think. And then there's another question that I'll just quickly touch on, and then we can turn over as well, around, you know, what about the current political climate? What's going on with the new administration, and also not just the new administration, but states. And I think what's a little bit paradoxical and hopeful with some of the reductions in funding and reductions in staff that are negative for public health and for medicine, I think there's some potential positives, and that there does seem to be a genuine interest in addressing diet-related chronic diseases and understanding that nutrition has got to be a core part of that, and not just at the federal level, but also in the states. Many states are actually now proposing or considering bills to remove additives, and Texas has a proposed bill to not only remove additives, but to reduce unhealthy food in schools, and even require nutrition education for all doctors trained in Texas. And so it's a bill, not passed, but so I think there's it's a very interesting and unclear time what's going to happen. But I do think that the food as medicine movement may actually accelerate and be supported by the current administration and by Republican state legislatures. So thank you to all the folks on my panel. Thank you to everyone for the great questions. I think it was really a terrific. One person did ask, where can I get the citation? So all of these papers are in a single issue of Health Affairs, which was published online yesterday. So go to the Health Affairs website. Maybe someone can put it in the general chat for everyone. But I'm pleased to turn this over to my friend and colleague, Dr. Kofi Essel, who's at Children's Hospital and also program director in food as medicine at Elevance Health.
Thank you, Dari. Really appreciate you inviting me in. This conversation, let's keep it going. We have a wonderful panel today. Our panel is titled Food and Nutrition Insecurity, Equity, and Justice. I want to introduce our three panelists, and we'll get started with their presentations. First and foremost, we have Amanda Hege. Amanda is the director of the Dietetic Internship Program for the Nutrition and Healthcare Management Department at Appalachian State University. We also have Dr. Mary Kathryn Poole. She's a postdoctoral research fellow within the nutrition department at the Harvard T.H. Chan School of Public Health. And last but not least, we have Illana Fischer. She's previously based at the Gangarosa Department of Environmental Health at the Rollins School of Public Health at Emory University. Amanda, the floor is yours.
Thank you. Thank you so much for the introduction, and it's an honor to be here today among so many inspiring leaders in food, nutrition, and health. I want to be a huge round of thanks for Health Affairs. You're shining a spotlight on this vital connection between nutrition and community health. And as a registered dietitian nutritionist, you can imagine that these issues are of utmost priority. I'm joined today by my colleagues Monica and Dave with Resourceful Communities, and Lenwood, Claire, Sarah, and Roland from Carolina Farm Stewardship Association to share about the local food purchasing agreement Farm Share in North Carolina. Advance the slide, please. The Local Food Purchasing Agreement is a federal initiative that funds the purchase of locally grown food to support small and mid-sized farmers while improving food and nutrition access for underserved communities. In North Carolina, the Local Food Purchasing Agreement is executed by the Carolina Farm Stewardship Association under the name of Farm Share. Originally launched in 2020 as a result of COVID and response and reaction to COVID-19, Farm Share started receiving funding from LFPA in 2023. Advanced slides, please. Through FarmShare, regional food hubs purchase local food from growers at fair market value. They distribute it through community-based organizations to those experiencing food and nutrition insecurity within the community. Within the first 6 months of 2024, FarmShare partnered with 217 small-scale growers to distribute nearly 74,000 healthy, locally sourced food boxes through a network of 117 community-based organizations across the state of North Carolina. FarmShare paid $2.7 million directly to those local growers. It's shown to address immediate food needs while strengthening the local food and farm business. It creates a win-win-win for farmers, communities, and families. By directly connecting local farmers, regional food hubs, and community nonprofits, FarmShare supports access to good nutrition as a cornerstone of advancing community health. Next slide, please. The purpose of our work was to assess and describe satisfaction, perceived value, and economic impact, the quality of food, and the community relations among the 3 stakeholders in the FarmShare program. As you've seen today, there's a great deal of research of the impact of food as medicine programs on recipients. What we were interested in looking at is how do you effectively engage local food and farm producers and nonprofits in this food as medicine space. So we can accomplish this first through conducting surveys, gathering insights from these 3 groups. Our farmers are small and mid-sized producers growing or raising food in North Carolina. Regional food hubs are those who purchase, organizations that purchase from the local farmers and distribute the food boxes through community-based organizations. The organizations includes a diverse set of partners. These are food pantries, health clinics, faith-based groups, schools, summer feeding sites, senior housing authorities, and physician offices. A total of 170 FarmShare stakeholders completed the survey, representing a broad section of program participants across the diverse state of North Carolina. It included all 100% of the regional food hubs, 30% of our local growers, and 77% of our community-based organizations. Next slide. The FarmShare program is shown to offer a significant value to these stakeholder groups. FarmShare offers good value-added service. Participation in it is worthwhile considering any additional time and effort, and it was recognized as the best choice for their organization when compared to other food distribution programs. It showed that all 3 stakeholder groups, the farmers, food hubs, and nonprofits, were highly satisfied with the program. We see strong agreement that it helped build new community connections as well. Next slide, please. A significant outcome that we saw is that 94% of food hubs expanded their farm partner diversity. They reached more minority, first generation, and women-owned farms. All food hubs increased the amount of relationships they had with nonprofits in the community, including healthcare centers and food pantries. They reported increasing engagement and advocacy work, offering more outreach initiatives, and launching nutrition education and wraparound services. These efforts helped educate the community on how to properly store, consume, and cook the fresh produce that was provided through the FarmShare program. All community-based organizations use this education to expand additional wraparound services. The community-based organizations additionally reported more nutrition education, cooking classes, but also going beyond food to getting to self-sufficiency, offering transportation support, housing, and pharmacy to further support the community's health. This demonstrates how FarmShare not only just provides food, but it strengthens partnerships and promotes community well-being. Next slide, please. FarmShare is shown to have a positive impact for the local farmers and food businesses. All farmers and food hubs reported increasing revenue. Farmers highlighted that they are selling their products at fair market value. 90% of farmers reported hiring additional staff. They reported increasing the hours of their staff and moving some to full-time. And they reported retaining staff, which we all know in the farming world is extremely important. They also reported extending their growing season and increasing their acreage. They highlighted how farm share is now a dependable, consistent market channel that they don't have to have any heavy marketing for. Additionally, it improved food safety. Farmers reported improvements in their food safety practices and infrastructure. Food hubs highlighted an increase in food safety as well, and a decrease in food waste. Community-based organizations also highlighted that their food pantry, they had less food waste because the recipients are getting the food that they want. Community organizations also reported that they are also sourcing more local food and raising additional funds to purchase that local food from the local growers that they're connected to. Next slide, please. So farm share stands out. It offers better quality, more nutrition, and culturally appropriate food. It offers more nutrition than other programs that food pantries offer. They rated the nutritional quality of a 5 on a 5-point scale. They heard from their clients that their clients are healthier and better overall due to the inclusion of that fresh produce, and that the cultural diversity of the food is meeting the cultural diverse options that the recipients are asking for. Next slide, please. This study, in closing, the study examines how these federal policies work on the ground in supporting local food systems and community food and nutrition security, focusing on those roles of the local growers, our regional food hubs, and nonprofits. It increased revenue and expanded stronger local food networks. But most importantly, it offered the nutritious, healthy, culturally relevant food that our underserved communities so deeply want. Policy and funding are essential to sustain programs like Farm Share and scale those. They provide a model for integrating local food and nonprofits into food as medicine. It's now my pleasure to introduce Mary Kathryn Poole, a postdoctoral research fellow in nutrition at Harvard T.H. Chan School of Public Health. Thank you.
Thank you so much. And thank you to Health Affairs and to everyone for tuning in today to learn more about this important work that you've seen today. So I'm going to present on some findings from a rapid review of evidence that I conducted with my team on how to understand and compare 3 economic assistance models to improve food security and diet quality. Next slide, please. So how best to address persistent trends in food insecurity and poor nutrition in the US is widely debated. And at the center of these debates are 3 economic assistance models that have been proposed as viable solutions. The first model is to modify existing cash-like food assistance programs like SNAP or WIC, where cash-like benefits can be spent on food. Some have proposed increasing benefit amounts for such programs or adding nutrition restrictions to what can be purchased. The second model is to use nutrition incentive programs, which offer rebates or vouchers, usually to purchase fruits and vegetables. Examples of this include the SNAP Healthy Incentives Program, where households can receive incentives to purchase nutritious foods like fruits, vegetables, or other foods that have been associated with improvements in diet-related conditions. And then the third model is to simply provide unconditional cash transfers that households can spend however they choose. This approach is newer to the US, but has been used in other countries for decades. All 3 of these models have their strengths and their detractors, but the effectiveness of such approaches has not been compared recently in a systematic way for the outcomes of diet quality and food insecurity. Next slide, please. So we followed established guidance to conduct a rapid review of these economic assistance models to inform many of the recent and ongoing policy discussions involving proposed changes to SNAP benefit amounts or what foods can be purchased, as well as the upcoming expiration of the Farm Bill, which authorizes SNAP. So for our review, we included US-based studies that evaluated one of the 3 cash or cash-like economic assistance models using an experimental or quasi-experimental design with a comparison group. to measure impacts on food security or diet quality. We included studies that were published between 2008 and August 2024, as these were most relevant to the post-recession economy. And we did have several other inclusion criteria that you can locate in the article online. Next slide, please. So after reviewing more than 3,000 records, we included 23 studies in our review, and all of them had very widely variable benefit amounts and study populations. So 12 of these studies focused on cash-like food assistance programs, which currently reach tens of millions of households nationwide. And so programs evaluated in these studies either included Sunbucks, which provided cash-like benefits to eligible families during summer months, SNAP-like benefits with or without restricted food items, or temporary or permanent increases to SNAP benefit amounts. 8 of the studies focused on nutrition incentive programs, which currently reach more than 100,000 households nationwide. And these studies evaluated incentives distributed as rebates for fruits and vegetables, either at point of purchase as a voucher or as a rebate, both that could be redeemed for fruits and vegetables. And then 3 studies focused on unconditional cash transfer programs, which have reached thousands of households in US cities or counties through pilot programs. And these studies evaluated monthly guaranteed income, or one study evaluated a one-time cash transfer. Next slide, please. So based on our review of the literature, we identified 3 main findings. First, increasing benefits for cash-like food assistance programs has the strongest evidence for improving food security, but mixed evidence for dietary outcomes. Related to this, we found that the addition of nutrition restrictions to these programs inconsistently improved diet outcomes, and fewer participants used their benefits when these restrictions were in place. Second, nutrition incentive programs prompted small increases in fruit and vegetable intake, but did not consistently reduce food insecurity. And then third, the available evidence for cash transfer programs is not yet robust enough to draw conclusions on impacts for either outcome. However, continued research in this area is needed, since this approach may address some of the barriers to participation in existing food assistance programs. Next slide, please. And so our findings suggest that continued investment in cash-like food assistance programs and nutrition incentive programs is essential to population health and local economies. Opportunities to enhance and expand these programs are needed, along with rigorous evaluations to determine which innovative solutions are most effective. In the meantime, reducing benefit sizes for these existing food assistance programs would undermine their large and positive impacts and would exacerbate disparities in food insecurity. We hope that our findings can guide future and ongoing policy decisions to ensure that the US continues to make progress in overcoming food insecurity and poor nutrition. Next slide, please. And then last, I'd just like to acknowledge and thank my co-authors, Dr. Matt Lee, Sarah Bleich, and Erica Kinney, and also our funding from the NIH for this project. Thank you so much. And I'll now pass it over to Illana.
Hello, thank you all so much for being here. I'm really honored to be here on behalf of my co-authors to present our paper, Food Supply and Dietary Guidelines Mismatch, Policy Recommendations to Improve Human and Planetary Health. Next slide, please. So as mentioned in today's briefing, there are a lot of obstacles to eating healthy foods, and we wanted to take a step back and look at the agricultural production and overall availability of these healthy foods. So despite the fact that dietary guidelines around the world encourage health-promoting diets full of fruits, vegetables, and legumes, and recommend limiting consumption of refined grains, animal products, and added sugars, we've noticed that global and national agricultural policies tend to have opposite priorities, and we have massive subsidies encouraging farmers to produce livestock, grains, and sweeteners rather than grow the nutrient-rich fruits and vegetables. So we wanted to take a closer look at this mismatch between dietary guidelines and agricultural policies to find out if our food supplies do allow us to meet the dietary guidelines. Next slide, please. So our primary research goal was to quantify if the food supplies of 12 diverse countries are sufficient in each category recommended by the Eat Lancet Planetary Health Diet. This is a set of guidelines that's focused on preventing chronic diseases and on promoting planetary health. Next slide, please. We chose these 12 countries, which account for over half of the world's global population and GDP. They also cover a range of income levels, climates, and dietary patterns. We used the food balance data from the Food and Agricultural Organization of the UN, which provides information on the calories available per capita per day in each country, and it accounts for production and trade. We divided the data into the 10 food groups from the Planetary Health Diet, and then averaged the data from 2016 to 2020. Next slide, please. So in order to compare the food supplies to the guidelines, we took the average calories available for each food group and each country and divided them by the amount of calories recommended by the Planetary Health Diet. This gives us a % of recommended calories available. So here we can see the big picture of what the data looks like. The first column shows the Planetary Health Diet, and it's followed by the 12 countries. On the y-axis, we have the 10 food groups. So the squares that are in blue tell us that a country does offer sufficient amount of calories of that food group, but the red and yellow squares mean that the recommended calories of that food group are not met by the available food supply. So we can see by looking at the horizontal rows that there is mixed availability for both the fruits row and the vegetables row, and that no country offers the recommended calories of legumes or nuts and seeds. To take a closer look at this heat map, you can reference it as an interactive exhibit on the Health Affairs website. Next slide, please. For this chart, we wanted to see how food supplies vary by income level, and we see that the high-income countries, by the dark blue lines, offer more calories than the low-income countries for most food groups, with the exception of the legumes food group and the grains. Next slide, please. All right, so our findings show that there is mixed availability of fruits and vegetables and an alarming undersupply of legumes and nuts and seeds. So in order to increase the availability of these foods, which fall into a category called specialty crops, we suggest 4 agricultural policy actions. Our first recommendation regards direct agricultural subsidies. So more than $500 billion goes towards agricultural subsidies each year, but only a quarter of that goes towards specialty crops. By redirecting subsidies from commodity crops, we could help farmers transition towards growing specialty crops and therefore increase the domestic supplies of fruits, vegetables, legumes, and nuts. Our next recommendation regards crop insurance, which is critical for the economic stability of farmers. Specialty crops can be more prone to risk than commodity crops. However, crop insurance for specialty crops tends to be less accessible and therefore makes growing specialty crops economically risky. Next, we recommend increased investment in agricultural research and development for specialty crops. These investments do have a high upfront cost, but have shown to have high returns on investments by increasing yields, reducing crop loss, and reducing food waste, all of which strengthens domestic food security. And then finally, we recommend a reduction in agricultural tariffs. Low agricultural tariffs help facilitate global trade, allowing regions with limited domestic production to access a steady supply of nutritious foods, while also providing important profits to countries with higher production of crops. The data that we used in this project tells us what food is available in each country after accounting for imports and exports. We don't know what the food supply of each country would look like without trade. But every country is interconnected and reliant on each other's goods. Recent restrictions on free trade will impede progress and improvements to global nutrition, and the future of human health depends on us working together. Thank you so much. And I'll pass it back to Dr. Essel.
Awesome. Thank you all for those presentations. We have some questions coming in the chat, so I want to go ahead and throw some of them out. Please go ahead and continue to throw some questions our way so we can make sure we answer any questions that you may have. Mary Kathryn, I want to start with you. So one of the things that have come up in what you presented, you highlighted sort of the role of federal nutrition programs, how sometimes, in particular with SNAP, you see sort of mixed results in terms of improvements in dietary intake, right? So improved dietary intake, but you do see consistently improved food security. So one of the questions is thinking about sort of pathways or mechanisms. What would you suggest is the reason why we may see some improvements in health outcomes, some overall health outcome improvements with SNAP, when you don't necessarily see consistently improved dietary intake?
Yeah, thanks for the question. I think, as you mentioned, the review that we conducted, we did find that there were some meaningful improvements in food security, but diet quality was more mixed. I think this really speaks to a lot of the structural and environmental conditions where people are using their benefits and purchasing food. I think a component that could be really useful in helping to better answer that question is doing more mixed methods and qualitative research, which really can help understand the lived experience of people who are participating in SNAP. There are documented barriers around enrollment and challenges with staying enrolled and coming on and off of benefits. So I think that there's definitely a need for more research around the question of diet quality. And from some of the studies that we did review, we saw that not having nutrition restrictions seem to help with participation, but the programs that did have nutrition restrictions seem to help more with diet quality. So I think really zeroing in on that question and having some mixed methods research will help to better answer why we don't see consistent improvements in the diet piece.
Thank you for that. Thank you for that. A lot of us also end up diving into the role of decreased stress that is persistent in households that are experiencing food insecurity, and the list goes on and on as well, which you've highlighted quite well. I want to go next to Amanda. Amanda, there was a question that came in the chat saying, with current cuts in USDA around the LCPA program, how does this affect your program in particular? Are you going to be able to continue to do the work you're doing, even scale the efforts that you have going on right now?
Excellent question. The cuts to USDA's local food purchasing agreement are already directly impacting the Farm Share program in North Carolina, and I would imagine other LFPA programs across the nation in their ability to procure fresh, locally sourced food at fair market value and serve that food to vulnerable populations. And so now more than ever, I think it's important for programs that are considering food as medicine and integrating local food and nonprofits and food as medicine work is to think about diversifying our sources of funding. It supports the local food and farm economy. So what state funding, maybe in the Department of Ag, is available? It supports food insecure households. And so what funding, maybe with Feeding America, farms to food banks type initiatives, is available to support those types of programming. And then we know through this research and beyond that it supports the health outcomes of communities, particularly in rural disadvantaged like Appalachia. And so what funding might be available from foundations? I'll call out John Lumpkin earlier, Blue Cross North Carolina Foundation. So I think right now more than ever, the cuts to USA are impacting these programs, and it's important to consider diversifying our funds.
Thank you for that, Amanda. Man, I'm going to come back to you one more time. I have a question here about data points. Can you share with us what data points you think would be valuable for future research to explore when it comes to looking and connecting the role of sort of local procurement and health outcomes? What do you think we should be looking at or exploring?
Well, it kind of ties back to that funding piece. I think we all know that so goes the funding, so goes our work a lot of times. And so I think it might depend a little bit on who's funding and what data points they're looking to see outcomes in. But in really looking long term, we should be working with health economists to look at, and local economists to look at the impact on the local economy from a farm and food business standpoint, but to also look at the cost effectiveness in the long term. I know that's been talked about as well. Do we need cost effectiveness in food as medicine, and how important is that? I think my thought would be, it's great to be able to show that. So how do we show that food as medicine is reducing healthcare costs? Some metrics there could be looking at emergency room visits, inpatient visits, cost for prescriptions, but overall prevalence of type 2 diabetes. You could go so far as be looking at those A1C and health metrics as well at the recipient level. The most important thing is to really in the future look at that economic impact, both on the local farm and the agricultural sector and on the healthcare sector.
Beautiful, beautiful. Illana, let's point a question towards you. So one of the things that you talk a lot about is different strategies to sort of change what we're doing to change the food system around us. What do you think are some of the biggest challenges domestically when we think about how we can increase investments in specialty crops over commodity crops?
Yeah, that's a great question. So right now in the US, we have about 4% of cropland dedicated to specialty crops, and the rest is going to mostly commodity crops, mainly corn, wheat, soy, animal feed and other livestock production. So a lot of those commodity crops receive large amounts of subsidies from the government and from specific organizations. And so that really dictates what a lot of farmers are able to grow. It's whatever is being subsidized. If we're able to sort of get a hold on some of those subsidies and redirect them in order to help farmers transition from growing these commodity crops towards specialty crops, that would help diversify the American production of crops. There was an example from Finland that did this over the past few decades, where the government took a really good public health approach, and it was called their Dairies to Berries project, and they helped a lot of farmers transition towards specialty crops, and that had really great effects on the health of the population.
I was actually going to ask you about that next. Can you talk a little bit about that North Karelia project?
Yeah.
Thank you for highlighting that. It was a great example in the paper. Amanda, here's a question for you. We talk about local investment. Dr. Lumpkin has highlighted that work as well. People are very interested in it. How do you scale those efforts? What are your thoughts on scaling? How do you think about that?
That's a great question. Yeah, how do you scale something at the county level, regionally, and then statewide? And I think that scalability is an important factor to consider. And the biggest need for scalability is people. We know that people, they build relationships with other people. And so by investing in the right people, we can ensure that scalability is possible. So for example, the Healthy Opportunities Pilot or the Medicaid 1115 waiver in North Carolina, they have regional networks that then connect to the state. So by having regional networks, you can still listen on the ground and ensure that those maybe the local farmers directly connected with the local food pantry site, but then they're still connected at the regional level that then connects them to the state level. And so by having people at the regional level that are talking to one another, and by having the right people and resources at the state level that are also connecting to the regions, you're able to scale efforts. You're able to create a standard of practice or a minimum service standard across the state, but still allowing for some flexibility based off of region, mountains, cultural preferences, and local food needs.
Great, great. Mary Kathryn, I'm coming back to you. Question for you. Did nutrition education modify the effects on diet quality or food security that you saw, or was that out of the scope of the paper? Can you dive into that a bit?
Yeah, we really wanted to be able to narrow in on being able to compare the cash value and cash-like benefit to one another. So we did not include papers that evaluated kind of multi-component interventions. So if there was a cash-like benefit paired with cooking classes or nutrition education, that would have been excluded from our analysis. So that wasn't an outcome that or an intervention that we looked at for this specific question, but certainly, I think multi-component interventions are critical across these issues. No one program is going to, reduce food insecurity or improve diet quality. So having multiple interventions in place that meet the needs and the interest of the population you're serving is critical.
Awesome. Amanda, it looks like we have another one for you. It said specialty crops, they don't have the insurance coverage like commodity crops. It looks like the farmers are incentivized. I didn't get a chance to read this, so change policies, public. What policy reports and campaigns and partnerships with farmer coalitions will be explored to move this work forward?
That's a great question. And others might be able to speak to this as well. So in the state of North Carolina, there's a farmers market network and a regional food hub network that directly supplies support for farmers in being able to supply food for food as medicine programs. So that's additional food safety training or additional GAP certifications or any types of additional support that might be necessary for the farmers to have the capacity in order to supply and have enough fruits, vegetables, and other healthy food to be able to supply for food as medicine.
Awesome. Well, listen, we are out of time. I want to thank everybody for joining us for our panel titled Food and Nutrition Insecurity, Equity, and Justice. So I want to thank our wonderful panelists for joining us as well. Next thing I want to do is invite our next panel to the stage. I want to introduce a wonderful esteemed colleague, Dr. Sarah Bleich. Dr. Sarah Bleich is the inaugural Vice Provost for Special Projects at Harvard University, Professor of Public Health Policy at the Harvard T.H. Chan School of Public Health, and faculty member of the Harvard Kennedy School of Government. Sarah, the floor is yours.
Thank you so much, Kofi, and good afternoon. Let me start by piling on my thanks to Health Affairs for supporting this issue on food, nutrition, and health. And I want to welcome all of you to panel 3, which is focused on government programs and policies. We are in for a treat. We're going to hear from 3 fantastic panelists: Jennifer Pomeranz, an associate professor of public health policy and management at New York University; Kurt Hager, an assistant professor in the Division of Epidemiology and in the Department of Population and Quantitative Health Sciences at the University of Massachusetts Medical School; and Kathryn Garfield, a clinical instructor at the Center for Health Law and Policy Innovation at Harvard Law School. Please submit your questions via the chat throughout the presentations. And let me now turn the mic over to Jennifer. Welcome.
Thank you very much. I'm just going to jump in. Our paper is about advancing the FDA's Human Food Program through additional authorities and user fees. We accomplished a lot in our 5,000 words. Next slide, please. And so first we examined some of the non-used and underutilized authorities by the FDA for pre-market control over food ingredients. The Food Additives Amendment of 1958 divided ingredients into food additives and generally recognized as safe or GRAS substances. There is no required submission for GRAS substances. And the problem is that the industry is the one that determines whether something's going to be GRAS or to submit a food additives petition. And then they decide if they decide it's GRAS, then they're actually allowed to self-identify the ingredient as GRAS and add it to the food supply without any FDA oversight or knowledge. This is called the GRAS loophole, and the Environmental Working Group found that 99% of ingredients are added through this loophole. There are other pre-market issues. FDA can't meet its statutory deadlines to review those food additives petitions and other things like new infant formula notifications. There are also long timelines for qualified health claims, and industry says that that delays innovation. Next slide, please. So also post-market, there are some very big concerns. The FDA does not have a rigorous, routine, or comprehensive post-market review process for ingredients already in the food supply. Of course, that's incredibly scary when we know that 99% of the ingredients are entering the food supply through that GRAS loophole. When they do identify evidence of harm, it can take decades, literal decades, to remove ingredients such as industrial trans fat and brominated vegetable oil after the evidence of harm has been very clear. In terms of food labeling, claims are required to be truthful and not misleading. However, the FDA does not issue warning letters for just solely misleading claims. It also lacks the authority to request substantiation documents. That's documents providing evidence substantiating structure function claims. That's why you see a huge range of structure function claims that are potentially unsubstantiated on a range of products like infant formula, drinks, cereals, etc. The FTC does have this authority, but the FDA does not. So it does not issue warning letters for structure function claims. Next slide, please. So there's also funding issues. The FDA, some of this can be explained by underfunding, some of it cannot. The FDA gets funded for its food program through appropriations. As the Supreme Court recently said, they must regularly implore Congress to fund their operations. However, in other contexts, the FDA actually gets user fees. 100% of the tobacco budget is funded through user fees. 66% of the human drug budget is funded by user fees, whereas only 1% of the food budget is user fees. This is through the Food Safety Modernization Act and color additives, but FSMA, the Food Safety Modernization Act, provides very limited user fees. However, the FDA hasn't issued a small business guidance document, so they don't actually collect all their user fees. Also, FSMA has authority to address unapproved food and color additives, but this does not seem to be utilized. Next slide, please. So just so everyone's clear, user fees are like fee for service. They're charges imposed on regulated industries for the actual regulatory activities. They don't fund outcomes. You don't pay a fee and then get an approved application. You pay a fee so the FDA can review your application. So that's the point of user fees. It's actually funding from the government to feed that regulatory process. Next slide, please. So policy solutions that we suggested was to close that grass loophole, which RFK Jr. has been discussing presently. We need a rigorous post-market review process for the ingredients already in the food supply. FDA should be leveraging that FSMA authority to identify unapproved food and color additives. FDA should be granted through Congress the authority to address structure function claims, but in the meantime, FTC should be acting on structure function claims on food. It rarely acts. Like Kellogg's immunity claim decades ago was an example, but it really doesn't act in this context. And then the FDA should be issuing warning letters for misleading claims. Next slide, please. The success of other user fee programs really informs that user fees can be supported by industry once they see the benefits of predictability of review timelines and streamlining of processes. The FDA actually will adhere to those timelines with the user fees. Next slide, please. So we suggested user fees for all FDA's pre-market food-related activities, all ingredient reviews, and also pre-market statutory deadlines and claims. Also, the FDA needs resources for robust, rigorous, and comprehensive post-market review. Post-market tends to be funded more through appropriations, but it could be either one. FDA should issue small business guidance under FSMA so it can collect the fees that it's owed. It's important to know the Supreme Court recently ruled that Congress needs to impose new user fees. The FDA cannot likely unilaterally impose them. And this is very relevant to the current administration, where they're trying to close these the grass loophole and address other issues in the ingredients in the food supply. And despite there's arguments that that fees lead to regulatory capture, currently, what we're seeing is that the food industry is policing and regulating itself. So we need an extra policy and resources for the FDA to actually have some type of oversight over the food industry. Next slide. Thank you very much. Feel free to email me or submit your questions here. Thank you.
And now we can pass things over to Kurt.
Great. Thank you, Sarah. So I'm honored to be here today presenting on behalf of an amazing team of co-authors who put in a tremendous amount of work to pull this study together. You can see the full list online on our study. I will be sharing results on the Flexible Services Nutrition Program, which was authorized using a Section 1115 waiver and it was implemented by Massachusetts Medicaid starting in January 2020. So we can go to the next slide. So a key thing to keep in mind is that these services were not widely available to the full Medicaid population. This was a highly targeted and tailored program. and also design in a way in which health systems could really pilot the services that were being launched. So in order to be eligible, a member had to be enrolled in a newly created accountable care organization, which is also a major component of Mass Health or Massachusetts Medicaid 1115 demonstration. Everyone also had to be under age 65, plus meet these two additional criteria on this slide. So at least one health needs-based criteria. You can see here they're fairly broad, so it could have included a behavioral health need, a complex physical diagnosis like diabetes or heart failure, perhaps need for everyday tasks and assistance with independent living, so having needing assistance for activities of daily living, high emergency department use, or a high-risk pregnancy. So one of those, and also need to be at risk for nutritional deficiency. In practice, all the ACOs involved met this criteria by screening for food insecurity. So everyone also had to have food insecurity. You can go to the next slide. So Mass Health designed the program in a way which gave ACOs a lot of flexibility to design and tailor the program so their members' needs, and to choose which social service organizations in their catchment area they wanted to partner with in implementing their services. In practice, we can see here there were a wide range of different food as medicine program models offered. Some of various models have been discussed in other presentations today. So this range from medically tailored meals, produce prescriptions, food vouchers, kind of food box delivery programs, in connection to federal nutrition programs. So our study reports outcomes for over 20,000 Mass Health members who received services from January 2020 to March 2023. On average, enrollment was just under 5 months. But there was also a lot of variation in how long people were enrolled, with some members receiving services for over 2 years. You can go to the next slide. So we were focused on acute healthcare utilization and healthcare costs in the study. These outcomes were components of our independent evaluation of the waiver at UMass Medical School. And we included primary care visits as a secondary outcome. The comparison group was Medicaid members who were eligible for flexible services, but who did not receive those services. And we employed a difference in difference study design. So this essentially means we compared rates of hospitalizations, emergency departments, healthcare costs in the baseline period, defined as the 6 months prior to receiving flexible services, to the change during the program period in which members were actually receiving flexible services, and compared that change between the two time periods between the treatment group and the comparison group. We accounted for an extensive list of potential confounders, including medical diagnoses, baseline healthcare utilization and costs, the referral ACO, and social demographics. More on our analysis, if you're interested, I would point you to the article, but specifically for those who want to deep dive, we outline a lot of this in the appendix, online appendix for the article. So we'll go now to the results. You can go to the next slide. So what we found was that enrollment in flexible services nutrition programs was associated with a 23% reduction in hospitalizations and a 13% reduction in emergency department visits. So the change in healthcare costs favored flexible services participants, but that difference between the comparison group was not statistically significant. So this was for the full sample, though, across all study years, for all 20,000 members included. But we chose to do a couple really important key subgroup analyses to dive deeper into the outcomes of this program, 2 of which I'll share now. So we go to the next slide. So it's really important to keep in mind that this program was launched in January 2020, right before the COVID-19 pandemic hit. So a huge kudos goes out to Mass Health, the accountable care organizations, social services organizations who were implementing this during that period of just immense instability and chaos. So we did decide to do a stratified analysis by the early pandemic and later pandemic, given the impact of the initial outbreak. And interestingly, we saw that in the first 2 years of the program, there was no change in any healthcare utilization and costs among all the members who received services during that time. However, in years 2020 or 2022 and 2023, this is a period when the vaccines are widely available, the economic shutdowns have largely stopped. We found an even greater reduction in hospitalizations and ED visits and a significant change in healthcare costs. So we did see that healthcare costs were in fact reduced among those receiving services. And if you go to the next slide, I'll report our final subgroup analysis. We looked at outcomes among adults and children. So interestingly, but perhaps not surprisingly, since children are relatively healthy and have a lot less acute healthcare use, we did not see any change in healthcare utilization and costs among children. For the adults, we did find outcomes were generally quite similar to the overall finding. And we also did analysis looking at different enrollment lengths. And one finding I'll point to here is that among adults enrolled for 3 months or longer, we found, again, a significant reduction in healthcare costs. However, this reduction in healthcare costs actually exceeded the program costs. And the program costs here included the cost of food and the administrative costs as well at the ACO and Mass Health level. So ultimately resulted in net cost savings of about $200 per adult member. And for this specific subgroup, that equals about 1.8 million in cost savings to the Medicaid program. So in conclusion, a large Medicaid-funded pilot of nutrition supports reduced hospitalizations and emergency department visits. Healthcare costs were significantly lower among participants who started after the COVID-19 pandemic and among adult participants who enrolled for 90 days or longer. So with that, I will pass it off to our final panelist, Kathryn Garfield.
Excellent. Thank you, Kurt. Today, I'll be presenting an article titled States' Use of Medicaid Managed Care in Lieu of Services Authority to Address Poor Nutrition, which I was honored to author with Erica Hansen, Carmel Shahar, Pascal Stein, and Darius Mazafarian. This article picks up on a theme that we've already seen raised on this panel. And that's what pathways does healthcare policy and Medicaid policy in particular offer to sustain and scale nutrition supports? Kurt described one of those pathways operating in Massachusetts, the Section 1115 demonstration waivers. Our article takes a deep dive into a second such pathway, Medicaid Managed Care in Lieu of Services and Settings Authority. Next slide. In lieu of services and settings, or ILOS, is a policy pathway codified in 2016 by federal regulations at 42 CFR section 438.3. Under this authority, state Medicaid agencies may authorize coverage of non-traditional services and settings as medically appropriate, cost-effective substitutes for services or settings already covered under the Medicaid state plan. Notably, these services can either be immediate substitutes, so services offered as an immediate alternative to another service, or forward-looking substitutes, so services offered to avert the need for future services. Once the state approves coverage of an in lieu of service, it must then identify the approved service in its managed care contracts and take the cost of providing those services into account when setting plan payment rates. It is then up to the individual plans to decide whether or not to offer the approved services to their enrollees. ILOS therefore provides a flexible pathway for states to experiment with new cost-effective approaches to care. However, analysis of state use of ILOS has been somewhat limited up to this point. Next slide. Our paper seeks to fill this gap by providing a survey of state use of ILOS authority, and in particular, use of this authority as a pathway to provide coverage of nutrition supports. We conducted our assessment by analyzing publicly available Medicaid managed care contracting materials from 39 states and the District of Columbia. 2 additional states that utilize Medicaid managed care were excluded as their contract materials were either not yet available or not viewable online. We also conducted a search of each state's Medicaid website to identify any supplemental materials or guidance that they offered regarding in lieu of service. A much more detailed methodology is described in the article itself, but you can see our search terms here to give you a sense of what we looked for. Finally, given that many states offer multiple managed care programs, we sought to limit our scope by focusing on contracting materials for really one large managed care population per state, excluding additional more limited programs such as those that perhaps just provide home and community-based services. Exact details on contracting materials we reviewed are available in the supplemental materials online. Next slide. So getting to the good stuff. This slide really summarizes our key findings. First, we found that the vast majority of our surveyed states, so 90% of our surveyed states, are using in lieu of services to allow coverage for at least one service or setting. In fact, we identified 135 distinct approved ILOS across the 36 states that we found to be using them. These ILOS fell into three broad categories. We found that 35 states had approved services or settings to address behavioral health, 14 had approved services or settings to meet general medical needs, 12 had approved services or settings to address health-related social needs, and of those 12, 10 used ILOS to address nutrition in some way. On this slide, the states with those nutrition services are identified in orange. The green states then show the other 26 states that offer ILOS, but only for services or settings that did not address nutrition specifically. Next slide. We found that states using ILOS to address nutrition also differed significantly in approach. We identified 4 states that had approved multiple food-based interventions, including California, Iowa, Michigan, and Minnesota. In contrast, 3 additional states, Kansas, New York, and Rhode Island, had authorized approval for meals and then some sort of nutrition education or counseling benefit. 2 additional states, New Hampshire and Tennessee, had authorized coverage of a nutrition education or counseling related service, and then a less clearly defined food or nutrition supplement service. And finally, 1 state, Oregon, provided really only an education focus in lieu of service, sort of alternative format specifically for diabetes self-management education or the diabetes prevention program. Next slide. So what did we take from these findings? First, we were struck by the fact the vast majority of states are using in lieu of services to provide coverage for at least one service. This really underlines the fact that states are aware of and employing the ILOS pathway as part of managed care contracting. However, we only identified 10 states as using ILOS to provide access to nutrition supports. And can I go to the next slide? There we go. Okay. In contrast, many more states use this pathway to provide alternative services or settings to address behavioral health. And I'll note that that trend is fairly consistent with some of the regulatory history behind in lieu of services, which highlighted the potential to use in lieu of services for behavioral health needs in places such as the original 2016 final regulation. Additionally, of those states using ILOS to provide nutrition supports, there was significant variation in approach, with only a small number using ILOS to provide access to a wide range of food as medicine services, such as the ones that you've heard discussed on the panel today, like medically tailored meals, medically tailored groceries, and produce prescriptions. And taken together, we feel that these findings showed both the potential of in lieu of services, but also the opportunity for further state action. We therefore suggest further analysis to better understand these trends, including qualitative research into how plans and state Medicaid leaders are thinking about this pathway, especially in light of the greater clarity that has been provided by regulations and guidance over the last 2 years. And with that, I'll hand it back to Sarah.
Thank you so much. That was a great presentation. And now we will turn to the Q&A. And actually, Katie, would love to stick with you. So we've heard in this panel about 2 policy pathways to address nutrition in Medicaid. Kurt talked about the Section 1115 waivers. You talked about the in lieu of services. Can you talk about how these policy trends intersect?
Yeah, that's a great question. And actually, it varies a bit by state. We sort of see 2 trends here. In some cases, there are states that are actually doing both, right? These are not mutually exclusive pathways. So for example, California, in developing its framework around nutrition supports, leverages both an 1115 waiver and the in lieu of services authority. Also, states like New York have authorized both in lieu of services and have a large 1115 waiver. In contrast, we also see some states where they really have one or the other, perhaps sort of explained by each other, right? So for example, we didn't find coverage of nutrition supports via in lieu of services in states like Massachusetts, but as you heard from Kurt, that may be in part explained by the fact that Massachusetts has a really robust 1115 waiver that is tackling that issue.
That's great. That's very clarifying. And one thing you also talked about in your presentation is that in lieu of services is only being used in some states to address nutrition. And so based on your analysis, how would a health plan that is interested in this pathway go about requesting approval for a new in lieu of service?
Yeah, so this is something else we looked at, because if we're thinking about in lieu of service as a pathway for innovation, I think it's really important to have clear guidance and policies to help stakeholders understand how do you propose new uses of it. So we did look for this in the materials that we analyzed, and we found that less than half did provide really clear guidance, at least in the materials we looked at. But some states, we did see some good practices around. For example, about 8 states had noted a very specific form that would have to be filled out in order to request a new service. And then we also saw some other interesting practices, like some of the materials from Oregon that indicated that they had sort of an interactive sort of discussion approach between state officials and stakeholders to sort of brainstorm and think about what new services could look like for this authority.
Got it. Thank you. And Kurt, let's stick with you or go back to you. And one question is, you've talked about a lot of exciting results from the Massachusetts 1115 demonstration. Are there similar nutrition programs that are being replicated in other states?
Great. Thanks for this question. So I would say the answer is yes. So there are now 16 states with approved or pending 1115 waivers that are directly paying for similar food as medicine programs. Again, usually quite tailored and targeted to specific populations in Medicaid. The one thing I do want to share, though, that I find personally very exciting is that so the first 2 states to receive 1115 authority to do this were Massachusetts and North Carolina. The North Carolina team actually published their results weeks ago, led by Dr. Seth Berkowitz, who presented earlier during this conversation today. And I'm encouraged to see that these are 2 very different state contexts, but overall our findings are quite similar. So both states found a reduction in emergency department visits and found a reduction in healthcare costs in certain situations. There's a few differences where North Carolina, they did pool nutrition and housing together, but it was majority nutrition. They also had a very large sample of about 14,000 people receiving services, but a lot of the nutrition programs were quite similar. And so to me, that's encouraging to see 2 different state contexts, 2 different studies coming out at a similar time period, generally showing that these 1115 waivers and nutrition programs can have a really meaningful impact on reducing acute healthcare utilization and can be highly cost effective and in many situations also cost saving.
Yeah, it's encouraging findings indeed. And one of the questions that came through the Q&A is that in addition to encouraging findings, there are some challenges to funding for new 1115 waivers. And you mentioned that there are several that are pending. So the question is, how would you recommend more sustainable funding sources for these programs?
I saw that almost might be a better question for Katie. I might pivot to her if that's okay.
Absolutely.
On this, Katie.
Yeah, absolutely. What I love about this panel is that you get to see that there are multiple pathways to doing this work. Yes, there are currently 13 approved 1115 waivers that include nutrition supports. There are 3 pending before CMS coming from DC, Rhode Island, and Nevada. So we're, of course, watching those very closely to sort of understand the continuation of momentum around 1115 waivers. However, that's not the only pathway that states can choose in order to really start going down this pathway of providing better access to these nutrition supports and really integrating them into healthcare delivery and financing. As our presentation outlined, another option is in lieu of services. That is a specific authority for Medicaid managed care, but the vast majority of states do operate a Medicaid managed care program. So that is an option for those states. Additionally, there are other pathways as well. So for example, for home and community-based services authorities, waivers and state plan amendments, there is also opportunity to build in nutrition supports there. And then even going further down at the plan level, plans also have the option through value-added services to provide access to these types of interventions. So there's really a whole array of options here, and we often encourage states to think about it in a stepwise process. That, where is the starting point that is available to you, and then how do you expand that over time?
Thank you, Katie. That was great. And Kurt, let's circle back to you. So you mentioned the Flexible Services Program, which launched in January 2020. Be curious to hear how the COVID-19 pandemic affected the nutrition programs, and how did you account for the pandemic in your analyses?
Great. So as you saw, we felt it was really important to do a stratified analysis during kind of the most acute emergent outbreak of the COVID-19 pandemic, into when some of the clinical care and economy had stabilized. And interpreting those results too, I think in a lot of ways this finding makes sense if we can think back to this period. I mean, the clinical care was completely disrupted. There were economic shutdowns. A lot of people in Medicaid likely were a lot less likely to work remotely. A lot of them had probably increased childcare demands with schools closed. And then on the flip side too, there was eventually, halfway through 2020, a really robust federal stimulus response. So greater benefits and nutrition programs, stimulus checks, tax credits for families. So it's very possible that in all this this chaos, and also much larger supports that both the treatment group and comparison group would have received, maybe washed out some of the effects of the Flexible Services Program. But I think it's just really interesting to think about when we think about other food as medicine research conducted during this time period. I'd be surprised if Massachusetts was the only place where we're finding some different effects in early COVID and kind of later COVID. But for the analysis, we also did two key things that I'll highlight. Is we did account for a COVID-19 diagnosis in the year prior to starting Flexible Services. And we also randomly assigned the start and end dates to the comparison group to match perfectly the start and end dates of the treatment group. So this meant that both the treatment group and comparison group not only had equal observation time, but that observation time was equivalent throughout all the waves of the COVID-19 pandemic, meaning both groups kind of experienced the pandemic in an even manner.
Thank you. That was great. So let's now turn to Jennifer. So first question for you, Jennifer, is there an example of an ingredient that entered our food supply through the GRAS loophole that has caused harm?
Yes, actually, taro flour entered the food supply through frozen products that people were ingesting, and hundreds of people got sick, and actually 25 people had to get their gallbladders removed from this taro flour. It entered through the self-GRAS mechanism, so there was no oversight. And this was recent. It was very recently, a year or two ago. So that's a good example.
So this next question for you, Jennifer, has multiple questions within it. So I'm going to read those off to you. Are you proposing that produce farms pay to be inspected under FSMA? How would that be?
I'm going to stop you because I don't want anybody to think we were not proposing farms should be subject to user fees. And I think and FSMA applies to food facilities. So we were not proposing anything about farms in our paper. They were specifically excluded. So I don't want to spend time worrying about farms. We would never propose user fees, and farms were not part of the paper.
Okay, thank you for that clarification. So Jennifer, when the industry decides for itself that an ingredient is GRAS, do we know whether they engage in rigorous science like we do in academia?
Yeah, so one of the biggest concerns is that actually they're allowed to rely on unpublished data. That's something we would never rely on, right? We would be laughed at during our peer review process. The other thing is when they engage in their own evaluations of GRAS ingredients, they use what are called GRAS panels, which are made up of 100%. Actually, Tom Neltner and his colleagues found that 100% of the people on these self-GRAS panels have financial conflicts of interest, and essentially 7 people on these self-GRAS panels with financial conflicts of interest decide the safety of our food supply. So it is actually quite alarming because none of this would be acceptable in academia.
Thank you. And I want to thank Jennifer. I want to thank Kurt. I want to thank Katie for the great presentations. We are at time for panel 3. And now I want to turn things over to the moderator for today's last session, Jessica Bylander, a Deputy Director and Correspondent at Health Affairs.
Thank you so much, Sarah, and thanks to the prior panel and all the previous panels. Such interesting discussions and really rich, and just a good example of how much information is in this theme issue and the breadth of topics that are covered. So for our final panel, I'm very excited to focus this panel on community voices. This is part of an effort at Health Affairs to feature more community voices and lived experiences within the pages of the journal and in other Health Affairs products. So I'll first introduce our panel. First, we'll hear from Jessie Lipman. Jessie Lipman is Program Director of the Roots Program at Kokua-Kalihi Valley Comprehensive Family Services. We'll then hear from Sonya Jones, a public health strategist at Henderson County Department of Public Health and the founder, board member, and former executive director of Caja Solidaria. And finally, we'll hear from Heather Thomas, Director of the A Place to Thrive and A Place for Kids programs of the nonprofit A Place to Stand. Mr. Lipman, thanks for kicking us off, and I turn it over to you.
All right. Aloha, my name is Jessie Lipman. I was born in the North American city of Madison, but I call Kalihi and Manoa home. I'd like to bring my ancestor Pauline to the event today. I share name, home, and ancestor with you because it's our organizational practice to do so in such groups. If we have more than 5 minutes, I'd ask you all to participate, but please take a few seconds to acknowledge the places you call home and the people who stand behind you. Thank you to the other presenters, our event organizers, editors, producers, publishers for the opportunity to share our work. I'm physically with you this morning or afternoon from Kokua-Kalihi Valley CFS, a federally qualified health center in the Ili'aina of Kuluo'opelena in the Ahupua of Kalihi on the island of Oahu, and speak on behalf of the Roots program and our contributing authors, Kau'i, Fiore, and Kahau. So this first slide, I guess, for you guys, celebrates the world voyage of the Hawaiian deepwater canoe Hokulea as a reminder that the original inhabitants of Polynesia had the capacity to sail the world's largest oceans 2,000 years ago, and they did so with a perfectly balanced assortment of nutritious food in the hulls of their canoes. The native people of Hawaii understood that systemic interconnectedness between nature, people, and resources created the harmony to consistently support a large population. With an expertly designed food system, people had the time to develop art, music, culture, science, and play. You all know about things like hula and surfing because Native Hawaiians had the health and time to get really good at them. Today, most of Hawaii's population are working long hours, multiple jobs, and subsist on a diet full of foods that cause sickness. Our work to address chronic illness is grounded in Aipono. Eating in health and balance focused on those traditional foods of the Pacific and the healthy things we grow here today. My mentor and our previous program director, Kaiulani Odom, is legendary in this movement to translate American health concepts like the food pyramid into models that better resonate with the local population and rely on foods we grow that are evolutionarily and spiritually connected to this place. We actually started our program as a demonstration grant 15 years ago, but we quickly evolved into a complete food system. So we nourish soil, we grow food together, we aggregate more food from local producers, distribute food as medicine through our food hub, operate a commercial kitchen to cook, preserve, and share food at scale, and use food to bring partners and community together to build relationships and create solutions to our needs and challenges. We turn our hands down to produce health and steward the land instead of holding our hands up, waiting for others to step in. Or as one child in our farm to school program said last week during her first time gardening, this feels normal. When I'm in the classroom, it doesn't feel normal. Our work crosses many cultures. Kalihi's largest demographics are Filipino, Micronesian, Hawaiian, and Polynesian. And if you look at the photo to the right of your screen, you'll see the mostly Filipina elder care class cooking participants making laulau, a Hawaiian dish, but they're substituting culturally familiar kamote or sweet potato leaves for the luau leaves in the preparation. Food has the unique ability to bring us together. While we do some standard quantitative dietary health evaluation, the Health Center has built indigenously informed Pilina Ha evaluation framework to study impact by measuring connection to place, connection to better health, connection to community, and connection to past, present, and future. And there's a citation to this rubric in the article, and you can explore it further online. Oop, I think I lost the slide, but despite the world's best growing climate, Hawaii imports almost 90% of our food. So we partner on a statewide level to build a stronger, sustainable local food system. And we source from that system as we partner with social service providers, healthcare, health insurers to innovate new paths to health that value personal and ancestral food memories. For us, it took over 200 years to break this food system. And it's going to take us a long time to heal it and restore it and reinvent it, but we're part of that process. And last month, like most community health centers, we were advised to scrub all references to diversity, equity, inclusion, and culture from our websites. But all of us, including all of you, are here today because our culture has built a healthy relationship with food. And here in Kalihi, we see the community get healthier when their culture is valued and perpetuated. That's my 5 minutes. At least time for the other presenters. Mahalo for your time and including our story in this journal. Thank you.
Sonya.
Thank you so much, Jessie. That was beautiful. I would like to start by acknowledging the team of people who work together to share our experiences through cultural and place-based wisdom in implementing food as medicine through this commentary. From Daisa Enterprises, Rochelle Bellin and Maham Rizvi. From Population Health Improvement Partners, Meredith Mastromoro. From Ram's Kitchen, Danielle Barber. Nourish Up, Chastity Glover. From Appalachian Sustainable Agriculture Project, Amy Marion. Hunger and Health Coalition, Maura McLean. Feast Down East, Susanna Spratt. And myself, Sonya Jones from Caja Solidaria and the Henderson County Department of Public Health. Next slide, please. Our commentary highlights the critical role of community-based organizations in delivering food as medicine services. While food and healthcare systems are powerful and crucial players in these programs, they also carry deep histories of discrimination and structural inequity. Building a road between the two institutions has to be done with some caution, lest we extract more from the communities that we seek to serve than we offer. In contrast, CBOs have always had to forge our own paths and define our own destinies. We're born out of cultural knowledge, community trust, and lived experience. In our commentary, we draw on disability justice and Indigenous scholarship to demonstrate how food, rooted in culture and connection, becomes true medicine. Given the short time I have for comments here today, I'll focus primarily on how CBOs carry the historical roots of our places and cultures and connect people with not only nutrition, but more deeply to our own roots through these processes. And I'm hoping to pique your interest so that you'll check out the rest of the commentary and learn more about the relational and deep care offerings of our organizations. Next slide, please. Our community-based food as medicine programs create culturally affirming spaces that honor the deep legacy of Black freedom movements in Central North Carolina using food. Historically, leaders from Charlotte's West End, for instance, fought for their right to eat in places of their choice. And all these years later, as urban renewal efforts displace what had become a thriving cultural and economic hub for Black residents,
Nourish Up is tending to food sovereignty in the heart of the West End community through food as medicine. Next slide, please. Ram's Kitchen in Gastonia shows that food as medicine is not just about nourishment, but about reclaiming cultural identity, where care is rooted in history, and sharing a meal can spark a new vision for community well-being. The Ram's Kitchen calls the historically Black high school, with its Rams mascot, into modern community life through its food is medicine programs. In Western North Carolina, organizations like the Appalachian Sustainable Agriculture Project, Hunger and Health Coalition, and Caja Solidaria harness the region's agricultural and cultural diversity to foster community resilience, integrating culturally important foods and creating space for connection and celebration. A food as medicine offering in these programs, for example, is the Candy Roaster, a traditional cultivar of the Cherokee people who carefully saved the seeds and have shared them with Appalachian settlers since at least 1925. Candy roasters are a storage crop, reminding us that communities have cultural strategies for food security and that these need to be nurtured and shared. Next slide, please. There's the candy roaster. Next slide, please. A national food as medicine movement strategy must continue to value the unique cultural grounding and deep care that only community-based organizations can offer. Next slide, please. As food as medicine expands, larger businesses and institutions are delivering services that often prioritize efficiency and standardization over cultural and care-centered approaches, threatening to sideline the essential contributions of community-based organizations. But only community-based organizations bring cultural grounding and safety, deep care, and create the nourishment that goes beyond food. Thank you so much. And next you'll hear from Heather Thomas.
Betty, thank you, Health Affairs, for shining a much needed light on these issues around food insecurity and nutrition insecurity, but more importantly, around the issues of food as medicine movement. My presentation is going to be a little bit different today because I am coming from a different lens. As you heard, my name is Heather Thomas, and I am currently a director with A Place to Stand. I oversee two of their programs, A Place to Thrive and A Place for Kids. These are programs that are serving families that are struggling with the different issues around poverty, such as housing, food insecurity, and other basic needs. It is through this work that I have been doing for now over 25 years that I bring a different type of lens to this particular issue. Because a few years ago, our family, who used to be on the other side of the counter providing direct services, we found ourselves needing the services that we had given so much help to, helping to connect people to. And so it is this type of lens that a different type of hunger, the article will take you. It will take you through our personal experience, lived experience with food insecurity, but also with nutrition insecurity, which we have heard today quite a bit about. This article will also give you a front row seat to the different complexities of the benefit system that currently exist within the United States. It will also help to break down the different myths that are there when it comes to thinking about the issues with poverty and what a person may or may not look like, what type of job they may or may not have when dealing with these issues, especially around food insecurity and nutrition insecurity. So with that said, mine is very short, but before I pass it back over to Jessica, I do want to give everybody a chance to really think about a time when you were hungry. You know, we all experienced that time when we were growing up, you know, as teenagers, going through different things, especially if we played sports or just got out of PE. Now think about that hunger and multiply it. And that's what a lot of households are going through right now. That hunger where you felt like you couldn't quite satisfy it and you couldn't wait to get home to eat something. Well, that hunger is very real for so many households in the United States. And there's so many people that are living within poverty, but also people in the Alice population that are dealing with these different issues around food insecurity and nutrition insecurity. As food prices continue to go up, and the ability to purchase quality, affordable food continues to decrease, you households are now starting to see more and more foods that are processed, less and less access to the foods that they need to nourish their bodies, and people are deciding who goes hungry. This is happening right now in this country. It's been happening for a while, but it's continuing to get worse. So think about that hunger and think about, as you move forward with reading these different articles that my fellow colleagues have written, and as you talk to legislators and you have these interactions, think about that hunger not being satisfied and what it's like to have that type of hunger and what it's like to watch maybe a child deal with that type of hunger. So I invite you to read this article, and I invite you to read all of the articles that are in this month's issue of Health Affairs, because these issues around food insecurity, the issues with food as medicine, the movement with food as medicine, all of these issues are so important. And if we want to see a healthier America, we're going to have to embrace these. We're going to have to really advocate collectively for these items. So with that said, thank you for having me. Jessica, I'm going to turn it back over to you.
Thanks so much, Heather, and thanks to all our panelists for their presentations. As a reminder, if folks have questions for the panel, please include them in the Q&A tab at the bottom of your screen. And I'd just like to start by asking, what avenues do you all currently rely on to include the voices of the community in healthcare policymaking in the food nutrition space? And also sort of, how's that going? How has that been working for you all? So maybe I'll start with Jesse.
Yeah, for us, getting the Medicaid waiver for traditional food and cultural practices has been a big thing. Hawaii's been working on that for a long time. And in January, that was just approved. I'm not sure how that's going to go with the new administration, but that can be a real groundbreaking way to move some of the resources of the health insurance industry into food as medicine work. Definitely trying to maximize SNAP benefits for our community. We do a lot to double SNAP benefits, to expand access to SNAP. Even WIC now has some opportunities. It's not just orange juice and beans and, the things that we knew when our kids were little. There's actually opportunity to bring a lot of fresh produce into that. So that's some of the things we focus on.
Thanks. Maybe I'll turn to Sonya.
Thanks so much. It's an interesting question. So across the different organizations, we've been thinking some about the types of policy advocacy that we should be doing at the local, the state, and the federal level. So at the federal level lately, of course, we're closely paying attention to what's happening with local food funding and how that might impact the ability of people to connect with local farms and foods that are grown in North Carolina. I'll speak from Caja Solidaria's perspective. We work really hard to be bilingual in all of our work and to show up with culturally appropriate and relevant food and cultural experiences at Caja. And so the ability to do that is really facilitated through the flexibility of the 1115 waiver in North Carolina and the ability to fairly reimburse and fund community-based organizations' work in a way that the community-based organization can show up for the community respectfully and treat people with dignity.
Thank you. Heather?
So for me, it's all of that, but it's also more in the sense of there's a lot of misunderstanding out there about if, for example, a family is getting SNAP and the amount of money that they can actually tap into for that benefit. So we need to educate the legislators, both locally, state, and at the federal level, on the realities of what people are actually able to tap into. Because a lot of times what's listed for their household size, they're not accessing that. They're not. it's very rare that you will have a household that can truly access the maximum amount. Most households are accessing much less than that. Some households I've seen even access as little as $25 a month for their household. And these are households that are living in poverty. That doesn't include the Alice population. So those are the things that really need to be looked at is what is the benefit level? What is the practice around the benefit level as far as having that access to the amount for your household size, but also increasing the eligibility to include those Alice populations into this because there's so many people that they don't qualify for benefits, but they need the benefits because they are also going, food they're food insecure and nutrition insecure. So really taking a different glance of it. The big thing is having people with lived experience at the table so that they can help create those policies and let people know what's realistic and what's not.
Yeah, and while it does feel like there's a growing recognition of the importance of lived experience and community voices, I'm curious from you all whether you've actually seen that trend, whether you've seen an increased, our policymakers becoming more receptive to having folks at the table, or does it feel like you belong there? And if not, sort of where do we need to go to make sure that feels like a space where community voice and lived experience is welcome?
I'll jump in. I think it depends on the issue. I think when you're talking about certain issues like childcare, for example, there is people are more receptive, our legislators are more receptive to have those conversations and to include those with lived experience at that table. But when you're talking about food and other issues, it's a very hit or miss at times. And so there is a growing movement, as you said, to include lived experience at the table, but it's still within a certain box that you're put when you share that lived experience. So you're kind of at the table, but you're not quite at the big table. You're more at the kiddie table when you think about Thanksgiving meals. So you're there, but you're not there. And until that shift changes and we really recognize the value of lived experience without tokenizing people, we're going to continue to have these issues. And things are just going to continue to perpetuate.
Anybody else like to chime in on that one?
Yeah, I guess just to piggyback a little bit on what Heather's saying, which table? Sure, people love to hear our stories and they love to lift up our stories and the things that are going well, but are they using them to make decisions, and which decisions? And we also have to challenge ourselves as community-based organizations to be led by people with lived experience, and that all of our work is based in those same values.
Yeah, I have a little story from here. They're privatizing the largest public housing development in Hawaii, which is about a block from where I sit right now. And there's a lot of community resistance to that. And we went through a process of reaching out to the community, uplifting community voice around that. And we heard from people in the community that they wanted us as the health center to really be a voice for that because we're the ones they trust the most. But at the same time, we're constantly taking a step back to make sure we're platforming those voices first. And we developed a real strategy around telling that story and presenting that to policymakers and the legislator here. I've gone to the legislature many times around food policy bills, and they're usually pretty detached. But I saw in this case when we were really mobilized, we had strategy, and we had diverse voices from the community. We'd inform the legislators about what was happening before we went, that there was a real change in tone. So I think, at least with some of the policymakers, they are thinking a little bit different about what's happening to people. For us in this community, and this goes back to what Heather was saying, like one of the things that unites Kalihi is everybody has known struggle in some way. Like maybe you're not poor right now, maybe your job is solid, whatever, but we all have had SNAP or, food stamps at some point, or have family members who have, or have people who are in the justice system or things like that. So we can all kind of relate to that. And that move to make this a quote unquote diverse mixed income community saw a lot of resistance because people value the fact that they can relate to their neighbors. And that's one of the things that connects us, is some of that class experience. So I see some difference with that, with legislatures, but I think you really have to be strategic in how you do it, and you have to have your stuff together, or you'll get tuned out.
Thank you. A question from the audience. First for Heather, why do you think there is that difference between childcare on one hand and food insecurity on the other, where the lived experience input is sort of valued or welcomed differently?
When it comes to childcare, I think it's easier for people to accept that you see children, they obviously need childcare if we want people to go to work. Everybody, whether you're middle upper class or you're in the working class, if you have children, you need access to affordable childcare. And so that's kind of something that kind of binds everybody. There's that connection piece, as Jess was talking about. Everybody needs somebody to take care of their child so they can go to work. So it's more accepted. There's not as much stigma. There's not as much shame. But when you're talking about food insecurity, that's a lot more personal. There are a lot of people still to this day that they're experiencing this, but they're afraid to go and try to get help for fear of that stigma and shame. And there's a lot of misconceptions about what a person with food insecurity looks like and what kind of person they are. It's the same reason we view homelessness differently. There's a lot of misconceptions. Oh, you must be lazy. Oh, you must not want to work. Oh, you just need to budget better. Oh, all you're doing is buying, processed food. And these are the types of barriers and things that are there for people. And so the mind shift is different because childcare is acceptable. These are kids. Food insecurity is still not acceptable, and it comes with a lot of shame.
Thank you. We have another question, and I'll probably piggyback with one of my own to sort of wrap up. The question is, how can communities and individuals with lived experience contribute to this sort of discussion and dialogue we're having today? And I think I would piggyback, maybe broadening it out to, if you could imagine a more perfect system, what would it look like to include community voices more meaningfully in policymaking? What avenues or ways of doing that could you envision? And this is a question for all of you.
I'll just start out with huge gratitude to Health Affairs for being so thoughtful about including community voices in this special issue, in a variety of community voices. I love that we started with a poem and that we're ending hearing from community-based organizations. So doing more things like this, I think, is one way to be inclusive and make sure that our voices are heard. And I'll go back to a point we make in the commentary and in this presentation, which is that community-based organizations have often had to forge our own paths and demand that our voices be heard. That's often why we formed to begin with, right? And those are our historical roots. And so in some ways, inclusion, fighting for inclusion, is the reason we exist. And so continuing to create spaces where we can be heard, feeds, enlivens, and enriches the culture of resistance and shared experience that Jesse referred to so beautifully before.
Kind of hard for me to answer that question because, like Sonya said, that's all we do. We're doing it all the time. So to step away from it and see it from a different perspective is kind of hard. Eat together, get to know your neighbors, spend time together, build connections, create places where community can come together. We have actually a lot of green space in this community, but it's very degraded. The only decent green space is right behind the police station, and a lot of people don't want to hang out and do their family gatherings right behind the police station. So creating good communal spaces where people can gather, that our public lands are made for people to come together, that our parks and our institutions are open to community and welcome them. Those are ways that we can improve.
And I think building on all of that, everything that was already mentioned, being willing to, when you are asking for that lived experience and you're asking for that feedback, being willing to hear some negative feedback if it is. A lot of times it's easier for organizations, whether you're talking nonprofit or government organizations, to say, we want to hear from you. But sometimes, a lot of times it's, we want to hear from you if it fits in this box. So we need to be okay with being uncomfortable if it's something that isn't way to go and it's more about, hey, this doesn't work, or this rule is not, realistic, or we don't like the way we were treated. Because one of the things I found as an advocate on, this side of it now is that people, welcome your lived experience. But when you start using your voice and advocating, and if you start noticing these different connections and wait a second, this doesn't make sense and this isn't okay, not everybody is comfortable hearing that. And so continuing to create these spaces, as you already mentioned, but also being okay with hearing that feedback, even if it's not positive, because that's really the only way we're going to change, right? And make things better and grow, is being able to go through those growing pains. So, yeah.
Well, thank you so much, Heather, Jesse, and Sonya, for participating in our final panel of today. Thanks so much. And thank you to all of our panelists and presenters for sharing their work and perspectives today. And thank you to everyone who attended, as well as the funders of this issue. We hope that you will also join us for some upcoming events. On April 29th, we will be featuring a conversation with Marion Nessel from 1 to 2 p.m. Eastern, hosted by Angela Odoms-Young of Cornell University, one of our advisors on this theme issue, along with Dariush Mosfarian. And also an event on April 23rd from 2 to 2:30 Eastern for insiders, Health Affairs Insiders members, Site Neutral Payments, a quick primer. A recording of this event will be made available on our website, healthaffairs.org. And again, thank you to everyone, our audience, our panelists who joined us today. And with that, we are adjourned.